lights that we've never seen. You said a change gon' come, not just for me, but everyone. And we pray on better days, believing you will set us free. But I'm glad that I know to run far away from you. Hey, finally, your promises don't mean a thing. Finally, your promises don't mean a thing to me, to them, my friend. You see, yeah. To me, to them, my friend. You see, yeah. Yeah.
Nearly every man, woman, and child can stand adversity. But if you want to test a man's character, give him power. Give him power. Give him power.
We gave you power to lead, not to abuse as I agree. We put our trust in you. You fed us lies and not the truth. Please don't pretend that you care. Give us back our stolen year. But I'm glad that I know to run far away from you. Finally, your promises don't mean a thing. Finally, your promises don't mean a thing.
to anybody at any time, and eventually you'll be able to hear me, and it's going
Ghetto is full of stars. Watch them shine from afar. On days when it's hard, and always Nana knows how to sing. And soothes us all from summer to fall, and always joy. She won't let it go. Oh no. Joy that she doesn't know, that she doesn't know. Tous on se perdre loin. Le mal ou le bien, qu'y a-t-il à la fin? Dis-moi comment faire le lien. Souvent je l'entends, au fond je le sens. Entends mes
Good morning, folks. Thank you. Thank you all so much for being here this morning. I'm absolutely thrilled to see you all in this room. I know many of you had a lot of travel challenges yesterday. I really appreciate you pushing through and being here. Uh-oh, yesterday, so there was a travel troubles elsewhere, huh? Thank you all so much for being here. I really appreciate it. So welcome. You're here today at Mental Health America's Regional Policy Council meeting, The Power of Pushback, Advocacy in Action. My name is Alicia Coffey, and I'm the Vice President of States Advocacy at MHA. It is my absolute pleasure to bring these remarkable speakers to you today. I have a few notes before we get started. The basics: the bathroom, out these doors, to your left, then on your right. We do have a break built into our morning schedule, but take good care of yourselves. Move around the room as you need to, come and go. There's water in the back, coffee outside. Now, speaking of our schedule, you will see on your table a QR code that'll take you right to our agenda. So please feel free to follow along today. Also, because I know you're going to ask, yes, we are recording, and you will get the recording, and you will get the speakers' PowerPoints after our event. Please give us some time to process all of that because there's lots of moving parts. I want to say thank you to those of you in the room who earlier this year took the survey I sent out to all of our affiliates asking you about what's working with the RPC, what keeps you coming, how can we think together about the RPC's vision for the future. Thank you so much to those of you who did fill that out. You gave me a lot of valuable information as I took this role on after Debbie Plotnick left. Some things I heard from you: you wanted more time to network with each other. We wanted more affiliates presenting from the stage, hearing about good work from each other. And you also wanted to get a little bit deeper into our presentations. So at this meeting, we're doing a few new things. I'm so excited to say that we have 4 affiliate leaders presenting from the stage today, in addition to our legislative award winners, the affiliates who are honoring award winners, and the affiliates you'll hear from as our core RPC leads. So we've got 4 additional folks on this stage, so I'm really pleased. Also, we've made presentations longer so speakers can get more in depth and you can ask more questions. So please be prepared to be engaged. We've put the time in. And then, to make sure that you all have networking time together as you have asked, we're also doing something a little bit different at lunch. We'll have a 15-minute pre-lunch presentation to charge you with an interesting topic to chat about while you have your lunch. So we're really trying to hear what you suggested and implement those suggestions. So you're going to see something a little bit different today. Another opportunity that the survey talked about was your interest in writing policy in your state and getting it passed. I'm mentioning it now because the lead staff person on that work is Tim Clement. Tim is here today, so if you would like to snag him to talk about writing legislation, please do so. We'll be hearing from Tim a couple of times today, so don't worry, you'll snag him. All right, I also want to do a thank you because this is quite a to-do that we put on, and we could not do it without our industry partners. We have AbbVie, Alkermes, the Bazooki Group, Bristol-Myers Squibb, Compass, Definium, and brand new, we have Eli Lilly. We also have Johnson & Johnson, Neurocrine, Otsuka, Pfizer, Supernaus, and Teva. So we're really thrilled to be able to do this work with their support. And with that, we're going to jump right into our first session. So, as you know, we host our meeting concurrent to the National Conference of State Legislators meeting and also the Council of State Governments meetings. Debbie Plotnick did a lot of work to create relationship with those two organizations, and I'm excited to continue that work. So today, joining us from the National Conference of State Legislators is Senior Fellow Carmen Hansen to make some opening remarks. Come on up, Carmen.
Good morning. Thank you, Alicia and Mental Health America for the invitation to be here today. I'm Carmen Hansen. I'm a senior fellow with the National Conference of State Legislatures, and I cover behavioral health and cannabis policy at NCSL and have for 25 years. Thank you so much for all of the work that you each do in your states. This is, there's never a bad time to be working on mental health, but there's also some very good times to be working on mental health. And thank you for all the work you're doing in this kind of post-COVID era as people kind of, seems like more slowly maybe than intended or ideal, getting back into like their regular kind of feel of life and things like that. So thank you so much for all your work. And also thank you for recognizing legislators and who are championing, not enough coffee yet, and it's been a long summit, championing these important issues in their states. There's truly no more bipartisan issue than mental health, because mental health is not political. It is not a partisan issue. So we just really appreciate the work that you all are doing in your states and working with legislators to educate them, because that's what NCSL does. We help legislators understand something better and connect them to the experts, people like you in their states, to get better information. Because the last thing I want to do as someone at NCSL is to have a legislator stand up and talk about a bill and say, well, I talked to NCSL and they said blah, 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 and it be wrong. So that's my job, is to help find them information that's accurate and to connect with other people that are working on these issues to help them get something accomplished that they're passionate about. So thank you. I do reach out to, I used to have Debbie on my personal cell phone on like the bat signal when I needed something. So I hope to continue that with Alicia, and reaching out also to you and other sponsors like Kelly and other folks that are here from the company. So thank you very much for the invitation, and I hope you have a wonderful meeting, and I hope to see you somewhere around. If you're attending the NCSL Summit, just give me a holler. Thank you so much. Multifocal.
Listen, I'm all right. Carmen, thank you so much. We're really thrilled to partner with you and to continue that partnership. So let's honor those legislators. Okay, I would like to invite Mark Harmon to introduce an Illinois state champion. Thank you, Mark.
Good morning, all. Nice to see you. So I've known Representative Tracy Katz-Mull for a long time. She was a student of mine. She's done well. And it's really my pleasure to present this award to her today. She was my student. She worked in the Mental Health Advocacy Project at the University of Chicago Law School, where she helped advocate for people with mental health conditions, and she was wonderful. I lost track of her after she graduated, and I was in Springfield and was testifying in a hearing on behalf of a bill that Mental Health America of Illinois had drafted to improve mental health conditions in Illinois. And we were in a large committee, and I have bad old eyes, and Representative Katzmo was in the very last row, and I didn't even notice her. She had just been appointed to the legislature and had joined and then appointed to the committee before whom I was presenting. And a number of legislators asked me pertinent or impertinent questions about my bill, which I tried to answer. And then all of a sudden, Representative Katzmo raises her hand and says, "Mr. Hireman was my teacher." And she also asked good questions about the bill and voted in favor of it, which is really all I cared about. So she's not getting this award because she's my student, even though having suffered through that, she's deserving of some award. But that's not how Mental Health America works, so they don't give awards for people just because I tortured them. We are lucky in Illinois to have committees on behavioral health, mental health in both the House and the Senate. And for those of you from other states that don't have that, I encourage you to work on it because it's been wonderful. And I mention that because Representative Katzmo is the vice chair of our House Mental Health Committee, even though she's only been in the legislature since 2024. She's very ambitious or very lucky or very successful or some combination of those three things. And people don't get on this committee because they were forced to. This is the kind of committee where all of the members, Republicans and Democrats, care about mental health conditions. And we're very lucky to have those committees and lucky to have Representative Katzmo as vice chair of that committee where she has played an important leadership role. I'll just mention a few things that she's accomplished in her very short time in the legislature. As I said, she's very ambitious, very successful. One is that, again, on behalf of Mental Health America, she sponsored a bill to undo a very strange provision in our law. You cannot commit someone in Illinois if they have pending felony charges. So that has become a more important and tragic omission in our law, as we are, I think, the first state to have abolished cash bail. And so that means we have many more people who have mental health conditions who are on pretrial release while they're waiting for their criminal charges to be resolved. And so they're out on pretrial release, and if they develop a serious mental health condition, they uniquely cannot be committed on an inpatient or outpatient basis. And Mental Health America has been trying to fix this for some time, and thankfully Representative Katzmo took a leadership role and got us halfway there, or an important way there, by removing the restriction for outpatient commitment. So now people who are facing felony charges and deteriorate can get the help that they need, because what happens if they don't get that help? They either violate the conditions of their pretrial release and go back to jail, which is, I suspect everyone in this room agrees, is not a great place for people with mental health conditions, or they commit another crime and go back to jail, which is also not a great place, not a way to get to jail. And she got this bill through the legislature after we'd been trying for years, and I really appreciate that. I'll just give one more example. We had an important bill to improve our health insurance law, and House Bill 1085, she was one of the principal co-sponsors of that. It improved the funding for, the reimbursement rates in private insurance for mental health and behavioral health conditions. That bill also got passed and increased the ability of the Department of Insurance to do enforcement. Representative Katzmull is on many important committees and related to issues that are closely related to the things that we as mental health advocates care about. As I think everyone in the room knows, gun safety is an important issue for people with mental health conditions. Substantially more people die by gun violence by suicide than by homicide. Representative Katzmull is on the Gun Safety Committee as well. She's also on the Appropriations Committee for Health and Human Services, and as I think everyone knows, money is where it's at. Money is where it's at, and then for variety, money is where it's at. So I want to thank Representative Katzmull. In 2 years, she's done so much, but we're mostly giving this award to her to make sure that she doesn't ever give up. Would you please come?
Thank you, everyone. Before Mark came up here, I told him, please don't tell them what my grade was. Usually when I'm presenting at a mental health event, I talk about my own mental health story, which isn't a dramatic one. I was a pretty good kid in school, but when I got an attitude problem in the 4th grade, my parents sent me to my first psychologist. He's actually still a fixture in my life, kind of like a older retired uncle. But because of the presentation today, I wanted to take a few minutes to talk instead about the case that I litigated with Mark when I was a member of the mental health clinic at University of Chicago Law School, because it's a case that I think about a lot and that has had ripple effects into my life personally and into my career now in the legislature. Myself and my law school classmate Kathy were the two 7-11 students who worked on a case called People versus Grant. And Mr. Grant had been at Elgin for many, many years getting treatment after he had been criminal justice involved and had been released into a community-based setting when he got a letter in the mail saying that his benefits were going to be changed and canceled. And he panicked. Instead of looking for a social worker or somebody who could have helped guide him through the process, he instead told his mental health doctor at that time, please don't let this happen, I still hear voices. Which wasn't actually the case treatment-wise for him, but it seemed to him the only way to ensure that he was still going to get his benefits. And because of that, he got sent back to Elgin, which was a much more restrictive setting than he needed to be in. And Mark got a call, where did he go, from one of our inside sources at Elgin back in those days who said, please, can your students represent Mr. Grant, because this isn't where he needs to be for his treatment. And so we prepared, and we had the law on our side, and we went in to do our first trial knowing we were for sure going to have a good result here because there hadn't been any issues at Elgin for Mr. Grant. It was really clear that this was just about having panicked about his letter. And yet we lost the trial that day. We lost because the judge didn't understand the law and frankly came across scared. And the prosecutor didn't understand the law and wasn't willing to engage with Mark or his students that day to talk about what the real needs were for our client who was in court. And so instead of being a trial where things were resolved quickly, we spent the better part of a couple of years appealing that case until it was eventually resolved in the appellate court. There were a lot of things I learned from that experience that affect the way that I legislate today. First of all, that you've got to fight the short fights and the long fights. That trial that day in the courtroom was intense. I remember sneaking to the bathroom at the break and kicking a wall, and my clinical partner being shocked by how upset and angry I was, as I sat there in the ladies' room saying, this isn't right? What's happening here is wrong, and it's going to affect his life for years. And it did, and we still had to take a breath and keep going and fight the long fight that was a multi-year appeal that eventually led to a reversal and him being allowed to return to a community setting. I learned a lot about judges and prosecutors that day. One of my other hats that wasn't mentioned here today is that I'm also a party officer. I am both a township chair, a Cook County Democrats officer, and now a state party board member. Who we choose to be our state's attorneys, our public defenders, our judges matters. It matters that they have humanity and that they see the people in the courtroom in front of them, no matter what their circumstances. I didn't see that happen that day, and I never forgot that. When I interview any candidate who wants to be a judge, who wants to be a state's attorney, that experience stuck with me. We didn't have a directed verdict that day, but we did learn a lot about treatment planning and what had happened in his time at Elgin. I learned for the first time about the impact of long-acting injectables for people who have mental health conditions. That also stayed with me. I know Mark mentioned a couple of the bills that I worked on today, but one that I'm really proud of from this year was a bill that was brought to me to start a long-acting injectables pilot at the Illinois Department of Corrections. I'll tell you directly that when the bill was brought to me, the bill's sponsor said, "Tracy, we're filing this bill. It's just one paragraph. We know this isn't likely to go real far this year." And the unspoken subtext there was because we were dealing with two populations, people in the Department of Corrections, people with substance abuse disorders, neither of which anybody would call the popular kids down in Springfield. But the bill resonated for me because of what I had learned so long ago in the clinic about the way that these forms of treatment can be life-changing. And I told them, I'll take your bill, but not if we're filing it just to plant a flag. I don't take bills for that. If we're filing a bill, we're filing the bill to run it to get across the finish line. And so we brought in partners to take that original one-paragraph bill and turn it into a 3-page, fully fledged out program. And I want to thank the team at John Howard Association and TASC, who are our most critical partners on that bill. Not only did we get the bill through the House committee and the House floor in a bipartisan manner, we had Republican votes both in committee and on the floor, but when we were told there was no funding, we figured out how to turn this bill into an ask to the Opioid Settlement Relief Board, and we figured out how to slip it in the BIMP. We play to win when it matters, even when we're fighting for the people that people aren't remembering to fight for every day. That came from what I learned in the clinic about those forms of medication and for fighting the long fight. The last piece of what I learned that day, people come back into your life when it matters. I'm not surprised that my professor shared the story that day. I teared up in committee when I saw him there. It hadn't occurred to me that this was something that was going to happen when I went back down to Springfield, or that we would get a chance to work together on a bill. The bill that he talked about was the bill that he was presenting in committee. And so when Chair LaPointe said to me the following year, will you take this over? I have so many things on my plate, but would it mean something to you to work with your professor to try to get this one across the finish line? Because I've tried a bunch of times and we haven't gotten there. I said absolutely. And again, people were in the right place at the right time. One of the biggest opponents pushing back on that bill was actually a proponent on one of my other bills. And it made them have to be a little more gracious. And so we figured out how to get one really important piece of that bill through. We're not done. There were still a lot of findings from that working group that said we could do more to make these forms of treatment more available and accessible. So again, short game and long game. As my professor said, I've only been down there 3 years. I'm just getting started. I raised my hand to volunteer to be a vice chair on this committee because it was work that mattered and resonated with me from both my life experiences and my law school experiences and now my professional experiences. So my ask to all of you today is please stay in touch. Please grab my name and information off of the board. Send me your legislative ideas. Send them through Mark or send them directly. The best ideas come from the experts in the community. As somebody who came at this as a lawyer, I am your most fervent advocate and you are my experts, and I can't wait to see what we get done next. Thank you so much for this honor today. Here? Okay. Oh yeah, the name tag. Thank you.
Thank you so much. It's nice to be inspired already this morning. Next, we have Tanya Fullwider to introduce an Ohio State champion.
I'm not sure which one I'm introducing Rob. Yes, I did. I did get her note this morning. Good morning, everyone. I'm Tanya Fullwider with Mental Health America of Ohio, and very happy to be here, having gotten in last night at a little after 11. So, good morning. And speaking of complications, the awardee that I'm introducing, we had some technical difficulties with her video. So you're stuck listening to me for a few minutes. So Representative Monica Robb Blaisdell is one of 4 co-chairs for our Ohio Legislative Behavioral Health Caucus. And Mental Health America of Ohio is one of the co-hosts, and we do various topics throughout the year. And Representative Robb Blaisdell is our newest co-chair, and she is just a superstar. She comes up with ideas. She is responsive. She comes on time and often early, well-prepared questions. Her talking points are ready. She's just been an incredible partner. So she's really fairly new to this space, but has really just made an incredible difference in bringing partners to the table, fellow members, and is just a critical partner for our Legislative Behavioral Health Caucus. So she is not here today, so I'm happy to bring this award back to her. So thank you. And I'm saying up here again, this one, fortunately, we do have a video, so I'm going to be very brief because Senator Weinstein's video is lovely, and I want you all to hear from him. I'll just briefly say we have been working on a bill that introduces care coordination following screening for perinatal behavioral health complications. If you've seen me up here, you know I'm often talking about mental health in the pregnancy and postpartum time period, and that is absolutely my life's passion. And when I started talking to Senator Weinstein about the challenges with screening in connection to care, he just got it. So we just have this wonderful bipartisan bill that he has championed, and we also now have identical companion legislation in the House that is also bipartisan. So it's been just a pleasure to work with him, and I'm just so glad to be able to honor him today.
Good morning, everyone. I'm sorry I couldn't join you in Chicago today, but I am truly honored to be recognized as a 2026 Mental Health Legislative Champion. Thank you to Mental Health America for this recognition, and a special thank you to Tanya Fullwider and the team at Mental Health Ohio for your partnership and support over the years, and especially through this work. One of the most rewarding parts of serving in the legislature has been seeing how this issue, how mental health brings people together. Regardless of political affiliation or profession or where you live, people recognize that mental health affects everyone, every family, every community, every workplace. That's why I've been so encouraged to see our amazing healthcare providers, employers, advocates, community organizations all rally around the same goal: to make sure every Ohioan can get the healthcare and the mental health care that they need. In Ohio, I've been really proud to work on bipartisan legislation aimed at strengthening support for perinatal mental health and improving access to mothers during pregnancy and after childbirth. This legislation is focused on helping moms experiencing mental and behavioral health issues and challenges connect directly with the care they need, rather than getting lost in a system of referrals and delays that is all too common in our state. While there's still work to do, I've been really encouraged by the broad support that this bill has received throughout our state. That broad support is exactly what gives me hope. Mental health is not a partisan issue, and the conversations we're having in Ohio are happening in state houses across the country. Organizations like Mental Health America play a vital role by bringing people together, advocates, providers, policymakers, community leaders, to share ideas, build partnerships, and keep this issue at the forefront where it should be. I'm grateful to the work and the many people who continue to show up to the State House in Ohio, and for what they're doing every day in their communities, and for the opportunity to contribute to that effort. Thank you again for this incredible honor. I'm grateful to be recognized alongside so many dedicated leaders in the field from across the country. I look forward to continuing to work alongside you, and I pledge that I will do that We're going to expand mental health care and build communities where everyone has the opportunity to receive the support they need. Thank you again so much.
Tanya, thank you so much for making solid nominations. It's exciting to have Ohio in the room. Okay, folks, now talking about states we have in the room, we're going to talk about my home state, Pennsylvania. We have Reggie Connell from the Keystone State. Hey. Thank you, Reggie.
Good morning, everyone. I'm Reggie Connell, Chief Operating Officer at Mental Health Partnerships in Philadelphia. And it's a great pleasure that I get to introduce State Representative Joe Hohenstein, who's been a champion at Mental Health Partnerships, and for to champion our causes and for all our participants. Representative Joe Hohenstein has been a tireless champion for mental health and dedicated advocate for mental health partnerships. His long-standing commitment to individuals living with mental health challenges is reflected both in his legislative leadership and his direct engagement with our organizations and communities we serve. He has been the lead sponsor for MHP's legislative proposals to increase funding for certified peer specialists, career development, health, and to strengthen, expand this critical workforce. He's also generously supported MHP by speaking at our graduation ceremonies, our press conferences, and using his platform just to elevate the voices of individuals in recovery and highlighting the importance of peer support services. Throughout his legislative career, Representative Hohenstein has consistently championed policies that improve the quality of life and promote inclusion. He has sponsored legislation to provide grants for recreational opportunities for individuals with disabilities, recognizing the importance of community engagement, wellness, and accessibility. In addition, he has supported requests to increase reimbursement rates for frontline workers, which is, something that's really needed, especially for our certified peer specialists and our direct service workers. What sets Representative Hohenstein apart is his unwavering commitment to place the needs, perspectives, and lived experience of individuals with mental health challenges at the center of his work. Whether advancing legislation, advocating for funding, or standing alongside community organization, he leads with compassion, respect, and deep commitment to equity. That's Rep. Hohenstein.
Hello, I'm Joe Hohenstein, a state rep in Philadelphia, and I am honored to be receiving a Legislative Champion Award from Mental Health America, and in particular from our affiliate in Pennsylvania, Mental Health Partnerships. Now, they've told me that this is a lot about the work that I do to advocate for certified peer recovery specialists, and that's important. But there's a lot of other aspects of mental health and health care that are really important. And one of the things I also like to focus on is kids and school bullying and all of the different issues that come up for children and their mental health and the access that they need in their schools and in their communities. And that's something that I've seen Mental Health Partnerships doing a lot of work on as well. And I want to make sure I commend them for that. When it comes to peer recovery, the thing to recognize is the power that comes when someone who has been on the path of addiction and has lived that life then is able to break free, get into active recovery, and reach back to help other people follow the same path that they have. That is a powerful thing, and that's something I'm going to always keep working on. So thank you very much to MHA and to Mental Health Partnerships for this honor. I'll keep doing my best to deserve it each and every day.
Next, I'd like to introduce Senator Nikhil Salva, who's also been a steadfast leader in advancing mental health access and a dedicated champion of certified peer specialists in the vital work that we do in our communities. His commitment to mental health partnerships extends beyond policy and advocacy. He is actively engaged with our organization by speaking at our certified peer specialist graduation, participating in our ride-alongs with our outreach teams, and consistently going above and beyond to support MHP's programs and mission. At the legislative level, Senator Saval has sponsored and supported policies directly benefit MH participants and the broader community we serve. His work is to protect access to health insurance for individuals living with mental health conditions, has helped reduce barriers to care and promote greater equity within the healthcare system. He has also been a strong advocate for affordable housing, another great need, recognizing that stable housing is a critical component of mental health recovery and well-being for our participants. In addition, Senator Saval has been outspoken in support of immigrant communities and has consistently worked to ensure that our most vulnerable neighbors are protected and represented. His leadership reflects a deep understanding of the social determinants of health and a commitment to building communities where all individuals have the opportunity to thrive.
Good morning to all the tireless advocates, the dedicated practitioners, and the brilliant policymakers who have come together in shared commitment to the safety, health, and well-being of communities across the country. I'm State Senator Nikhil Saval, and it's my honor to represent the people and communities of Pennsylvania's 1st Senatorial District, which runs through the heart of Philadelphia. I'm humbled for this recognition, and I wish that I could be with all of you in person for the opportunity to advance the work of government at all levels in increasing access to vital health resources, including mental and physical health care, as well as housing, family-sustaining jobs, and safe and flourishing communities. All of us, regardless of where we live, what we do, or what we have experienced, need and deserve to have access to care and support that meets us where we are and allows us to heal. Mental health partnerships does this by building hope, promoting recovery, and centering the role of peers who can understand our struggles intimately. When you support one person, your care touches every aspect of their life and ripples outward. In this moment of political and material hardship, your work is an act of radical empathy. And your work day in and day out has a direct impact on the work that I'm able to do. When you elevate the stories, the struggles, and successes alike of those you serve, I carry these with me to Pennsylvania's capital. When you create policies that support the needs of youth, my office can connect our youngest constituents with care appropriate to their needs. When you deflect people with mental health and substance use needs away from involvement with the criminal legal system, the communities that I serve are safer. I cannot serve my constituents without your diligence and care and devotion. Thank you for all that you do. I look forward to continuing this work together.
All right, Pennsylvania is on the board. Fantastic. How exciting is it to hear a legislator talk about not just diversion, but deflection, right? He's hearing from you, right? Our legislators hear from you. And today we're hearing them repeat some of our talking points back. It's because of the work you do. All right, I'd like to bring Barb Johnson up. Oh, fantastic. And Abby, wonderful. Turning it over to you, ladies.
Good morning, everyone. I'm here. I'm Barb Johnston. I'm the Director of Policy and Advocacy for the Mental Health Association in New Jersey. I'm here with my colleague, Abby Lewis, who's manager, and works alongside with me. And today we're pleased to recognize New Jersey Assemblywoman Andrea Katz for her outstanding leadership, her compassion, and her steadfast advocacy on behalf of New Jersey citizens who are impacted by suicide and behavioral health conditions. Assemblywoman Katz, in her second term representing New Jersey's 8th legislative district, which includes communities, for those of you who know New Jersey, across Burlington and Atlantic counties. She was just elected in 2023, and she became the first Democrat to be elected in that district in 5 decades. She's currently a resident of Chesterfield County in Burlington, Chesterfield Township in Burlington County, and she's a mom to 3 children. She chairs several committees: Agriculture, Natural Resources, serves on Transportation and Independent Authorities, and Telecommunications and Utilities. But in addition to mental health, her legislative priorities include strengthening public education, expanding affordability, and supporting agriculture and environmental conservation. Assemblywoman Katz became a leading mental health advocate in the legislature, drawing on her own experience as a person impacted by suicide. She's championed legislation that addresses the growing behavioral health challenges we all face, from minimizing the impact of social media, which has affecting youth, and improving access to community-based care. Her work always reflects a thoughtful, forward-looking approach to one of the most pressing issues facing our communities today. And Abby's going to tell you a little bit more about some of her more specific work.
Hi. So to give more context on the Assemblywoman, this past legislative session, she introduced a bill package to strengthen online protections for young people and promote research into the effects that social media has on mental health. The bills passed the legislature and now await the governor's signing. If enacted, online service providers will be required to refigure their data collection methods to protect minors' privacy and provide age-appropriate privacy and safety protections. Assemblywoman Katz is one of the leading advocates in fighting for funding for New Jersey's 5 crisis-receiving stabilization centers. That's been a longtime priority of MHA&J. The centers are a critical component in New Jersey's 90-day continuum of care. They would serve as somewhere safe to go for people in a behavioral health crisis. They're currently unfunded in the state budget, and she's been working with us and other advocates to do all that we can to receive funding. She visited one of the centers this past May to raise awareness of their purpose and be very vocal about the need for funding. We're continuing to work with her and other behavioral health advocates to continue fighting for funding. We're really proud to have nominated Assemblywoman Katz for her legislative leadership in mental health and congratulate her as a 2026 legislative champion.
Hi, I'd like to thank the Mental Health Regional Policy Council for awarding me the 2026 Legislative Champion of the Year. I'd also like to thank the Mental Health Association of New Jersey for nominating me for this award. I'm sorry that I couldn't be there with you tonight in person. I'm still here in New Jersey doing a lot of work. This award really means a lot to me because when I was a little girl, I didn't think that I would be sitting here making policy. Life wasn't easy for me. I was an at-risk kid and my mother lived with addiction and mental health issues. My grandmother had custody of me for a while and I'm very, very grateful. But I knew my whole life that I was always one parent, one family member away from the foster care system. I'm grateful for the folks who helped me along, and it's really important for me to make sure that everyone in the state of New Jersey and everyone everywhere really has access to the mental health care that they really, really need. In New Jersey, we've recently passed and are waiting for the governor to sign bills protecting our kids on social media. This is really important. Our kids are exposed to so much more than we ever were when we were kids. Their mental health is at risk and it's paying the cost for all the time that we spend on social media. The bills that we passed, the Kids Code Act in New Jersey, is going to be a step in the right direction to making sure that our kids are protected and safe online. But we can't stop there. We need to make sure that everyone in New Jersey has access to everything that they need when they need it. And that includes making sure that our mental health crisis centers are adequately funded moving forward so that folks in the middle of a crisis, when they pick up a phone and they call 988 and they call looking for help, they can get that help. They can get that help immediately and make sure that they can get the help that they need. So thank you guys so much. Thank you all for doing the work all year long to make sure that mental health is a priority in the policies that we enact across this country. Thanks.
You go first.
Thank you so much, everyone. Absolutely thrilled to honor these hardworking legislators, and thank you all for your advocacy, because they wouldn't talk like this without us. I'm inviting our next speaker to the stage. We are going to have Mary Giliberti, the Chief Public Policy Officer at our own Mental Health America, to offer an update on federal policy. Thank you, Mary.
Good morning, everyone. So I'm going to cover federal policy in 10 minutes or less. So I'm going to be speeding through. But if you have any questions, the federal policy team, Karen, Tim, myself, we're here. So come grab us and we'll fill in on anything that I talk about today. So I'm going to talk about, what's happening in Washington, D.C., and why does it matter? And I'm going to start with the money. Show me the money, right? So appropriations. Every year, Congress appropriates money for, different grants and different programs. And this year's no different, even though it's an election year. So that is a little different. And the House is already out. So they've gone away for the summer. They'll be back very briefly, and then they'll be out again to campaign. Before they left, they passed a bill, we call it a continuing resolution, or a CR. What does that mean? It means that when the money runs out at the end of September, they just kick the can, and they get the same amount of money for those months until the continuing resolution runs out. And this one would run out in early December. So they kind of just push things away. So we don't have a shutdown, which we really do not want. Waste a lot of money and time. So the Senate is in for another 2 weeks, and of course, they're not just going to do the easy thing and do what the House did. I worked for the Senate. They do not think that the House knows what they're doing, and so the Senate wants to do something different, and they want to have some additional money for different things. They want their bill to be bipartisan. The House was not bipartisan. It's kind of the way the two work sometimes. So they're going to see if they can pass something in the next 2 weeks. Civics, can't pass different bills, you got to come together, pass the same bill. So we'll see what happens. The good news is everybody is talking about continuing resolutions and not having a shutdown, which we do not want, as I said. So people have talked about the short game and the long game. One other thing, when you're playing the game, anybody play chess and you see that move, if you miss the good move, you see it after you take your hand off your piece, you're like, how did I miss that, right? You have to get the opportunities when they arise. And one of the opportunities at the end of the year, after the elections, we hope, there'll be an annual appropriations bill. And we call that the train, because you want to put anything that you've worked on during the year, any bill, onto that vehicle, because it's one of the few that's actually going to go through. Right? So we got 3 things we're working on, MHA priorities, that we're hoping to ride the train, the appropriations train. The first one's a relatively new thing we've been working on, but it seemed like it was moving, so we jumped on board, and that's a bill that would add more behavioral health integration services to federally qualified health centers. Would require them to provide those services and give them more money to do so. Many of them already do so, but they don't have enough resources. So this bill would add $250 million a year, which is good, right? Good news. And it was wrapped into a bigger package on health pricing, transparency, and went through the Energy and Commerce Committee. And Tim worked to get us a Republican co-sponsor, so it's a bipartisan effort. Tim Kaine, who some of you may know, recently suffered from depression and came back to Congress, and he is a co-sponsor. He's also working on some parity legislation with us, so exciting times on some of these bills. Another one is, they mentioned it in New Jersey, kids' online safety. So MHA is all about prevention, getting upstream, hard to be more upstream than dealing with social media and children's mental health. House passed a bill called the Kids Act, has some provisions in it, not quite as strong as the Senate bill that passed before, does not have a duty of care with respect to mental health harms. So we prefer that. That's in the Senate version from last Congress. But it did have some good language on preemption. Preemption's a very large word, but it basically means whether the federal law does not allow states to do their laws, right? And we don't want that. We want states to be able to do stronger laws, and we have a federal law, right? So the House bill had pretty good language on preemption. Now we move to the Senate. They passed it last Congress. We want to move it through the Senate again. And there's a lot of controversy about what is the preemption language going to be for not only social media, but also AI. And you can imagine the companies, which give a little bit of money to Congress, just a little bit, are very interested in this preemption conversation. So we'll see what happens, but we're actually fighting hard to get a strong social media mental health bill for young people out of Congress. Senator Blackburn, where's my Tennessee contingent, is leaving this year, so she's a fierce advocate for this. So it's kind of like this is the opportunity in the game. And then last, the Early Minds Act, many of you have advocated for that. It came from the affiliates. This would take a piece of the community block grant and allow states to use it for prevention and early intervention. Right now, they can only use it downstream. We got some nice report language. We need statutory language. So Tim's been working really hard with our Republican co-sponsor to try to get us using some techniques to get that language into that train when it gets passed. So we're hoping if we don't get it this year, SAMHSA reauthorization is next year, and we're going to try again and keep working that long game. All right. That's the Congress. Lots more happening, but those are just a few of the highlights. Now I'll talk a little bit about the administration. We are calling this time period Comment Palooza because there are so many things where they're asking for comments, requests for information. I have no idea if they read any of this stuff, but they ask for a lot of it, right? And you feel like you should talk about it. And then we do try to follow up and meet with federal officials to kind of emphasize our comments. So 2 areas, I call them like kind of the tale of 2 cities. We have a decent regulation for Medicare. So older folks have a lot of political power, and the Medicare reg is actually, I think, pretty interesting, and we'll be commenting on that in early September. It does things like kind of tries to move upstream, pays more for behavioral health integration, which we've been asking them to do, ups the reimbursement for behavioral health in general, has some new ways in primary care of getting upstream, things like shared visits, things like other ways that they can, coaching, health coaching, so you can do more in primary care to keep people healthy, right, which is something that we always favor. So we'll be commenting on that reg. The reg that wasn't so good was the community engagement Medicaid regulations. And you're going to have an entire presentation on that later, so I'm not going to get into that. The one thing I did want to touch on is some context, because people don't really know that role that MHA's national office played in some of the HR 1 language. So I do want to just touch on that. So HR 1, as you may remember, created community engagement. We like to call them the work requirements. People know it more by that, in the Medicaid program. So we were all opposed. Many of you, I'm looking around, went and talked to your legislators about why this was not a good idea, hadn't worked in the states that it was tried. But when it looked like it was inevitable, it was going to happen whether we liked it or not, MHA's team, we proposed language that would require states to use their data to see if people were exempt. In the HR 1, it had some language saying states had to use their data on the work requirements, so job data. And we proposed adding a few little words there that would also apply that to the exemptions. Now remember, people with disabling mental disorders and substance use disorders are exempt. So by having the states do that, right, use their data, we could help a lot of people not have to be part of this, that need coverage, right? So I just want you to have that context. Lindsay will talk later about the ex parte rules, about the how this will affect people who don't have data and have to come forward with the exemptions. And the rule is not what we would hope for. It added some requirements that will make it more difficult to implement, and more people will lose coverage. But you're going to hear much more about that. But I wanted you to have the context of what your national office does and how we look to opportunity, even sometimes just to make something that is not good a little bit less bad. Right? So you kind of have to do both. You have to try to do positive things, and also when something's going to happen that you don't like, and it's very tricky, like when do you start doing that? And we had to make a judgment about that back in that time. A couple of other regulatory changes. OMB, the Office of Management Budget, issued a rule, proposed rule, saying that, said a lot of things, but one of the things that was most concerning was that a political appointee, even mid-grant, could stop a grant because it did not comport with the administration's values or thinking on something. And that has never been the case before, and Karen worked on regulatory comments. Tons of people commented. I think there will be some litigation if that, on this rule eventually, and it is not what we would want to see, right? We want people to be able to plan, especially all of you who get federal grants. Another concerning development had to do with the Olmstead case. Just to show how many people know about the Olmstead case. Oh, good. All right, so I won't spend a lot of time on that. That was a Supreme Court case. I actually worked on that case when I was a young lawyer that said that people need to be served in the most integrated setting appropriate to them, right? It was two women who had mental disabilities and had been institutionalized only because community services were not available for them. And now the Department of Justice issued a legal memo saying they don't think the ADA, the Americans with Disability Act, requires the integration mandate or requires states to provide those community services and serve people in the most integrated setting appropriate. Mark and I think they're dead wrong, but nonetheless, that is their position. And we are going to be continuing to look at amicus briefs. We are seeing work in states to say to states that they shouldn't follow this. This is an interpretation, right? It's just the agency's interpretation. It doesn't change the law. So hopefully, later this will be changed as well. It's the administration's view, and there's some litigation going on where they will probably take this position, and it is concerning, but hopefully, eventually, we will return to the way the ADA is supposed to be interpreted, in my view. Also, so those are some of the sad things. I want to just hit very briefly on some very positive things, so I'll leave on a positive note. Lots of good things happening in the areas of psychedelics. In the last month, we've seen FDA issue guidance on clinical trials. We've seen the HRSA, Health Resources Services Administration, issue a request for information on the infrastructure and training that's needed for psychedelics. We've seen MOUs between VA and HHS, and these are new treatment options, so it's an exciting time. FDA is continuing to do its work to make sure that we have safe treatment options, but it's interesting to have new ways of thinking and new treatment options for people for whom other treatments have not been working. So it's an exciting time in that area, and the administration has been very supportive, doing an EO, an executive order, and now all these other pieces. There'll be an event in the fall with FDA that we hope to continue our advocacy moving forward. I did want to just mention our young leaders. You know, we have a young leadership group, and they are participating as well. They recently filed comments in response to requests for information on youth participatory research by the NIMH, National Institute on Mental Health. They talked a lot about youth peer support and how to empower young people in clinical research. So we are training the next generation of advocates to play the game, right? You have to know the rules. And they are just incredible. They have incredible knowledge of youth peer support and other areas. And it's just been so exciting to work with the next generation of leadership in this area. And I'll just also mention that SAMHSA has released some of its grants that were held up. So those of you who are interested, very short window, so take a look at that. And Timothy Westlake has been nominated our Assistant Secretary of Mental Health, so we'll have somebody at SAMHSA, which is great. And finally, and I'm getting to the end, tomorrow is an event at HHS on the recovery agenda. I will be there. Pierluigi Mancini, our acting CEO, and Jessica Jackson will be there. It is looking and talking about evidence-based care, including clinical care pathways that Patrick Kennedy and PsychHub are working on. And MHA plans to work with them to make sure the voice of lived experience is included in some of the provider trainings. So we're excited about that effort as well. So that's everything, and I want to conclude with a very heartfelt thank you to our partners, to our affiliates. We could not do this work without you. Congress people do not want to hear from us. They want to hear from all of you who are in their districts, and to our industry partners too, who help us and keep us updated and work with us. We just couldn't do all this work without all of you. So thank you so much.
Mary, thank you so much. I appreciate you leaving us on a positive note, but the idea of pushback, if it was all positive, we wouldn't be able to do any pushback. So here we are today, Mary, also talking about the great work being done to manage some of the challenges that we get handed as far as policy goes. So thank you so much for sharing the good work of our federal policy team here at Mental Health America. So our next presenter is Amber Kirchhoff, the Senior Vice President of Public Policy and Advocacy at Thresholds. I'm excited today to hear Amber talk about her work to help pass Illinois Joint Resolution number 52.
Okay, very good. Hello, everybody. Good morning. As she said, my name's Amber Kirchhoff. I'm the Senior Vice President for Public Policy and Advocacy at Thresholds, and super excited to have the opportunity to speak with you all today and welcome you to Chicago. I got to meet a number of folks last night and know that many of you traveled from other states to be here, and I know the weather has not been very forgiving, so thank you so much for making the trip and glad that you made it safely. I am going to talk a little bit today. I got to say, this is a little bit of a different talk than I normally get. I get invited to speak often about sort of the technical aspects of policy, what it means for the sector, what our advocacy strategy is. But I'm hoping to be a little bit more inspirational in my comments today. So hopefully we hit the mark on that. But today my talk is about advocacy in turbulent times, and we're going to borrow some lessons from the work of the Healthy Minds, Healthy Lives Coalition. So I'll tell you a little bit about that coalition. But first, let me tell you what Thresholds is. If you're not familiar, Thresholds is one of the largest and longest serving, and I forget I'm advancing my own slides here. Thresholds is one of the largest and longest serving community mental health centers in Illinois. We serve the greater Chicagoland area. Annually, we serve about 14,000 folks who have serious mental illness, substance use disorders, or dual diagnosis. That includes youth all the way through the rest of the lifespan. And so we've got a number of specialized programs for the deaf community, for mothers, for youth, first episode programs. We do quite a bit of supportive housing. And really our mission is to empower folks with home, health, and hope. And I should also mention that we are proud 2026 recipients of the Bell Seal Award, recognizing us for our commitment as an employer to mentally healthy workplace. So thank you all for that acknowledgement. Our team was really excited to be able to claim that this year. So we are already partnered with Mental Health America in that way. And Thresholds also has the good fortune of organizing the Healthy Minds, Healthy Lives Coalition. So this is a statewide advocacy coalition. It's a multi-sector coalition. We've got folks with lived experience. We've got providers. We've got trade associations, other health advocates, individual clinicians and practitioners. Just a whole host of folks. I will say we are a coalition of the willing. Our cast of characters varies a little bit from year to year, depending on what we're focused on. We've gotten to work on a number of different issues, including prevention, early intervention kind of work, and expanding access for youth and coverage for first episode treatment. We've created the Housing as Recovery program, which is a rental assistance and supported housing program, which actually is one of the initiatives that we worked on this year. So I'm going to talk a little bit more about that here in a second. And then was referenced earlier that Representative Katzmall was a champion for another bill that we worked on, which was House Bill 1085, that included a number of private insurance reforms to expand access and address some network adequacy issues that we were seeing for folks with private insurance. So we've worked on Medicaid, housing, private insurance, and really, I am here as the messenger, but I should say I've been back at Thresholds for just under a year now. I was on board when we launched the Healthy Minds, Healthy Lives Coalition about a decade ago, if you can believe. But this work, again, is really a team effort. So just want to recognize the other members of the Healthy Minds, Healthy Lives Coalition who are in the room today. So if you're a Healthy Minds, Healthy Lives Coalition member, if we can have you raise your hand so you can be recognized. Like I said, I'm in good company here today and proud to be able to be our spokesperson. All right, now you can think of me as a little bit of an extension of Mary's presentation. She recapped some of what's been happening at the federal level, and I don't have to tell you all that it's been rough. If we look back over the past year at sort of what's been happening on the federal landscape in the mental health space, it's been a lot, to say the least. So I'm going to recap a little bit of that because I think it's really important context, and I think it's why we're here today, right? We want to think about how do we sustain ourselves when everything feels so heavy these days. So just over a year ago, on July 4th, President Trump signed the Federal Reconciliation Package, which you've probably heard to referred as H.R. 1. That's how I'm going to refer to it. And that codified sweeping reforms to Medicaid. And Medicaid, as you all probably know, is the nation's largest payer for behavioral health services. So any changes to Medicaid are a really big deal for our space. And as a result of the changes, which will go into effect in January of the coming year, we're expecting that millions across the country will lose coverage and therefore access to care. Not because they're no longer eligible, unfortunately, but because they will not be able to keep up with the paperwork and the new requirements and barriers that are going to be introduced. Here in Illinois alone, we're also expecting to lose significant federal investment to our state health agencies. We're expecting to lose something on the order of $50 billion with a B dollars over the next decade. So this is just a really, really incredible challenge. And Illinois is certainly not alone. Also last summer, the president began deploying the National Guard and immigration agents to cities across the country, including right here in Chicago. And for many, the presence of federal agents has not increased their sense of safety and security, but rather it has created a lot of fear and distress and trauma, to be honest, in our communities, and for good reason. And just to remind us that we're talking about real people and not just headlines here, I want to spotlight a story of an individual who was impacted by this. Those of you who are from Chicago may have already heard this, but some of you who are not may not have. I know there's so much happening these days. It can be very overwhelming, but on October 15th, immigration agents detained a man named Omar Huerta Cisneros. He is a lawful permanent U.S. resident living with schizophrenia. He was detained near his home on the southwest side of the city. His family did not have any information about his whereabouts for nearly 2 weeks. They took to social media, posting, trying to find him. They reached out to their member of Congress. They alerted the local media. They engaged the Mexican consulate. They were doing everything they could to try to find their loved one. Eventually, he was reunited with his family. He was found about 30 miles from home. He had been released. He was alone. He did not have any support. His family did not know what had happened to him in the interim. They suspect that he was taken to the Broadview facility. So again, when people say that they are not feeling safe, it is for good reason. Like I said, there's been a lot of trauma that folks have been experiencing. In September, so just a little bit later in the year, the president issued an executive order entitled Ending Vagrancy and Restoring Order in America's Streets. This order really laid out a concerning vision for the president's plan at the intersection of behavioral health and homelessness. We agree with the president that unfortunately there are far too many individuals who are experiencing homelessness who are also struggling with behavioral health challenges. But unfortunately, where we diverge is what we should do about that challenge. And so some of the things that were proposed in the executive order were a move away from permanent supportive housing and harm reduction, rolling back consent decrees, which I couldn't really fathom at the time, but now we've seen this DOJ Olmstead memo, so now we have a better sense of kind of what he had in mind, and a call for a return to institutionalization, which obviously runs counter to what so many of us have worked for so many years. Later in the year, HUD issued the federal Continuum of Care NOFO, Notice of Funding Opportunity. I know not everybody works in the supportive housing world, but the Continuum of Care is a really important program for individuals with disabilities and folks with behavioral health needs. This is the nation's single largest investment in homeless assistance. And NOFO and the one that has come out subsequently propose to dramatically divest from permanent supportive housing, which we know is a critical resource and just foundational for folks being able to recover and engage in treatment. By January, more than 2,000 grants totaling over $2 billion were terminated without notice. And, you know, that was critical funding for education, prevention, treatment, recovery services. It would have been devastating. Thankfully, there was such swift backlash and, you know, really bipartisan support for so much of this work that within 36 hours that was repealed and those funds were reinstated. More recently, as Mary was referencing, OMB issued a proposed rule making significant changes to what's called uniform guidance. Essentially, these are the federal regulations around federal funding awards. And as Mary said, there were a lot of concerning things, so many of us probably submitted comments, but some of the most concerning were the pre-review or pre-award review by a political appointee to determine whether or not a project was considered in line with administration priorities and national interest, and the ability to terminate a grant mid-cycle, also a significant curtailing of appeal rights. So there were a lot of concerning and really big changes outlined there. And then, of course, we heard about the DOJ, Department of Justice, issued a memo reinterpreting the landmark Olmstead Supreme Court decision that has long been the bedrock of community-based care for individuals with disabilities, including those with behavioral health needs. Obviously, this would be devastating if they moved away from defending the community integration mandate, really paving the way for states to back away from community-based services and moving towards a return to institutionalization. And to add fuel to the fire, you know, much of this puts a lot of pressure on state governments too. And I think that, you know, when a lot of us have been doing advocacy work, we have been sort of looking to the state to maybe backfill some of the funds that are lost or to put in place protections. And so when the squeeze is on the state, that makes us all feel even a little bit more helpless. So what do we do? Where do we go from here? You know, at a time when things feel really heavy and when advocates are frustrated, deflated, upset, maybe even outraged, scared, worried, when we're not feeling especially powerful, when we're not feeling especially hopeful, when it feels like good news can be hard to come by, how do we maintain our resolve? When there are so many policy rollbacks, there are threats to funding, there's adverse rhetoric, how do we continue the fight? How do we stay encouraged? How do we keep people engaged? How do we keep pushing back? The focus of our conversation today, I think, is really twofold. It's not only how do we hold the ground and protect what we have built so far and elevate our cause, but it's also how do we maintain our integrity and preserve the spirit that we bring to the work. So in short, it sounds a little cheesy, but advocacy is our superpower. And so I think what I'm hoping to impart to you today is that we really have to look to harness the power of community, seize the moment and create our own platform and raise our voice in a way that makes a difference. So I'm hoping that we can use the work of the Healthy Minds, Healthy Lives Coalition as a little bit of an example for how advocacy can serve as a form of resistance. So you can think of us as a little bit of a case study. And I'm going to ask Alicia, can you keep time for me? Because I promise that federal overview is the longest of my slides, but I am known to run long, so keep me on track if you can. So we pursued two initiatives this year in the face of everything that I outlined today that was happening at the federal level. We pursued a resolution, and we also pursued an appropriations request. The resolution was really in response to the president's executive order. We found this really concerning. We wanted to make sure that our state legislators were aware of what was being proposed, because we know that it doesn't just end with the executive order. We know that eventually the things in executive orders often make their way into policy changes, into notices of funding opportunity, changes to the regulations. So we know there's just so much happening these days, right? And so it's difficult for state legislators to keep track of everything. And so we said, well, what can we do to raise this to their attention, to make sure that they're aware, and to remind them of all the good work that's been being done in Illinois on a bipartisan basis for so many years, and to ask them to stand with us and recommit to what we know works, the policies of person-centered, community-based, evidence-backed treatment. So we decided that we would use a resolution as a messaging opportunity for that, to help us to educate and to ask them to recommit and stand with us. Alongside that, as a complement to sort of this, like I said, more education kind of messaging tool, we said, well, we want to do something that makes a concrete difference for people. So how can we take this to the next level? Well, we decided to also ask, sort of as a companion piece, for additional funding for the Housing as Recovery program. The Housing as Recovery program we had created about 5 years earlier as a pilot project. It's a rental assistance program for folks who've really been spiraling because they don't have the stability of housing in order to meaningfully engage in treatment. We knew that that program had initially been seeded with one-time funding. Those were ARPA dollars, so that was being spent down, that there would likely need to be state dollars to help to backfill those funds. And we knew that the program was relatively small, but there was so much more need out there. And so we really also wanted to be able to grow the program. So as a complement to HJR 52, and there was a Senate joint resolution too. I'm not going to keep referring to the bill numbers. They had the same language in them, but for the purposes of the conversation, we had a resolution and an appropriations request. So from there, we had to think about how will we get other folks on board? How will we line up co-sponsors? Basically, how do we make these a reality and get them past this session? So we worked with the Healthy Minds, Healthy Lives Coalition to develop the language for our resolution and to determine what our target funding level would be for Housing as Recovery. We decided that we would ask for getting the funding up to $10 million for Housing as Recovery. We also had to identify legislative sponsors. We did that based on their committee assignments and their previous commitment to the issues. We also wanted to take this opportunity to build new partnerships, right? Oftentimes we go to the same champions. We have people who we know are reliable and very invested in our issues, and we always want to keep those relationships strong. But we said, let's work with a few new people too who are in committee leadership as an opportunity to build new relationships. We then developed our fact sheets and began circulating those with legislators and inviting them to come on board and to come on as co-sponsors. So we prioritized our outreach by members who were on key committees and caucuses, the Mental Health and Addictions Committee, the Housing Committee, the Appropriations for Health and Human Services Committee. And these might, be a little bit different in your state, but you get the idea. And we engaged both parties. So Illinois is a strongly Democratic majority, so oftentimes Democrats are in leadership and they're chairing the committees. But like we said, we don't see this as a partisan issue. Many of the things that we've been able to accomplish, including the things that I said, stated some of those achievements at the beginning, those were bipartisan, had bipartisan support. So, we always strive for that. And so we reached out to folks on both sides of the aisle and invited them to become co-sponsors. And then we kept working the bill through the process. So we testified at committees, we had subject matter hearings, we also issued action alerts to keep our base engaged, to keep them informed about what we were doing, to make sure that they had an opportunity to reach out to their legislators at key points in the journey. And then as we were sort of rounding out session, getting into the last couple of weeks, we also worked with sponsors to circulate a Dear Colleague letter, which is essentially a sign-on letter that goes to leadership, and another way to elevate what we were looking to do. As you can imagine, when we get into the final days of budget making and session, it can get a little bit tricky, and so you want to do what you can to raise awareness. So where did all of this get us? Where did we end up? Well, we were successful in passing our resolution, and like I said, really our goals with that were to increase awareness about the administration's vision for what we should do at the intersection of homelessness and behavioral health. So we were able to secure that on the record commitment from a number of our partners in the legislature to continue to pursue investments in community-based treatment and supported housing. And then ultimately, Housing as Recovery, it received a small funding increase. It was nothing on the order of what we had asked for, so it was essentially flat funded. However, I don't count this as a loss. I still count this as a win because we made some really important progress. By having those conversations with legislators, we elevated the profile of the program. We made them aware about how many people were benefiting, how important this was, the lack of capacity, the need for future investment. And as you all know, policy work is iterative. And so, we have to do a lot to build the momentum, and sometimes it's a multi-year effort. So what can we learn from what we did, and how might this sort of fortify you for your advocacy efforts to help you to feel inspired to keep pushing forward? I kind of curated some takeaways that I hope will be useful tips to you all. I think one of the first things that came to mind when I said, well, what would I want to leave people with, was community. And I think I have co-conspirators up here. I kind of regret using that verbiage, but please know that I meant co-conspirators in a good trouble sort of way, to take a cue from the late great John Lewis. So essentially what we're saying here is find your people. There's a lot of power in community. It's a source of resilience. You want to convene with others who share your priorities, your vision, your goals, feed off of one another's resolve. And on those hard days when you feel like you're losing your gumption, you borrow some from a friend. Convene with others who share your plan and want to, like I said, be part of your coalition of the willing. And then I think another important part of this work these days is a space for some catharsis. I know that helps me a lot when I can sort of commune with others, just to acknowledge that this work is really heavy. We ground ourselves by acknowledging the frustration, the fear, the angst, the consternation that people are experiencing right now. And sometimes we need to make space to let our guard down with like-minded individuals and just say, this is really hard, and sort of honor and validate that struggle, and say the work's a little heavier than usual these days. Another piece of this is finding folks who are aligned with you. Sorry, I'm skipping one. Another piece of this is creativity. So we're in unprecedented times. Advocacy might need to take new forms. For example, I've never run a resolution before. I usually think of them as a little fluffy. They're not always very substantive. Oftentimes they're used to commemorate things, but we really needed a tool, like I said, to bring attention to what was happening. We didn't necessarily need to change a law. So we said, this tool fit the bill. So consider all the different ways that you can reaffirm and uplift your position, whether that's running legislation, offering public comment, which was talked about earlier, signing on to letters, requesting a proclamation, filing a resolution, placing an op. There's so many different ways that you can uplift your message. And get creative with creating your own platform and amplifying your message. You may also need to be strategic in the way that you deliver that message in order for it to be heard and to be considered. That's part of the creativity as well, is the diplomacy and threading the needle on how best to deliver your message so that you can be effective in advancing your cause. And then also collaboration and coordination. And I'm also realizing I have a thing for alliteration here because we have all C's today. But collaboration and coordination. We need to identify partners with aligned interests. And just to give you an example, even in addition to the coalition, which is a broad cross-section of stakeholders, we partnered with folks in the housing space and anti-homelessness advocates to have our initiatives included as a part of their agenda for supported housing day at the Capitol. Similarly, we worked with the behavioral health trades in NAMI, Illinois, who sponsor a behavioral health advocacy day. They included our priorities as a part of their agenda. So that really amplified our reach. We had that many more messengers for our work. So figure out who those folks are who are like-minded and aligned, and how you can leverage and support one another's work. We can't lead on everything, but we can support a lot of things. And then lastly, celebrate. Again, this all feels really heavy these days, so don't forget to sit back and celebrate your wins and uplift the victories, small as they may be. I started out with a lot of places that felt like we weren't winning, but in fact, there were wins along the way. The fact that within 36 hours, we got $2 billion in grant funding reinstated is a huge win. That didn't happen on its own. Absolutely. That happened because folks like all of you gave voice to that, reached out to your members of Congress, and made that possible. Thank you. And there have been a number of court cases that have been filed in some of these instances. So, for example, the HUD Continuum of Care NOFO, we were able to get a preliminary injunction ultimately that what would have been a really harmful set of changes did not go into effect. And like I said, we got a resolution passed this year. We did a lot of work to raise awareness about what was happening. So those are just some examples. You have to celebrate your wins. That helps to keep people engaged. That helps to keep us sustained. And to acknowledge the hard work that everybody's putting in, right? That doesn't cost anybody anything, but it makes people feel a little bit stronger in continuing on. And last, again, like I said, I wanted to leave you all on a positive note. I want you to feel encouraged. I want us to think about how do we sustain and keep our resolve in times when it feels really difficult, because there is a lot of important work that needs our attention. So I just wanted to leave you with a quote that I always find myself returning to, which you've probably heard before. But if you'll indulge me, it's from Margaret Mead, who was an anthropologist, and she said, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." So thank you all so much for all the work that you're doing and the opportunity to share a little more about what we at Thresholds and the Healthy Minds, Healthy Lives Coalition have been doing, how we continue advocacy and sustain ourselves in the face of, a really challenging environment. Please do keep in touch. I've included the places that you can find and keep in touch with both Thresholds and the coalition, as well as me, if that is of interest to you. So with that, I'll take any questions if we have any time left.
We absolutely do have time for questions. I will run this mic. Hi, good to see you.
This was so inspirational. I don't know if this is on or not, but I'm loud enough, I think. So thank you so much. I'm just curious about, I think we got it right. I'm just curious about finding people, right? Finding the stories, connecting them with policymakers. Can you talk a little bit about that? Because obviously it's so important for everybody here to figure out how do you make those connections.
Yeah, absolutely. Like I said, we have a pretty diverse coalition. If you ever meet me, you'll know I am not shy, so I don't hesitate to introduce myself to people and continue to build that work. I don't meet many strangers, my mom likes to say, and so I think that's part of it, right? Is like I said, you kind of have to put it out there. This is what we're doing. We're always open to new members. We also work really closely with organizations that work with folks with lived experience. That's how so many of us come to this work, right? Is that we have lived experience of our own, or we are family members of people with lived experience, and so we work really closely with the NAMIs, who have a phenomenal training in place to train up advocates and folks to use their story for advocacy. We created a social media page to try and help raise our visibility for folks who don't naturally run in our circles. But we're always open to anybody who's sort of in support of our mission of expanding access to community mental health. So I think we just keep touting that. We take every opportunity that we have to do presentations like this to reach new audiences. We also have, we share some things out on some listservs too. So I guess some of this, we really do benefit from some of the infrastructure that's already in place to support advocacy in Illinois. So for example, we have a mental health and substance use advocates listserv that anybody, once you're at, it's a Google group, anybody can share information out. And so we will share meeting announcements there to kind of help us to recruit. Initially, the 10 years ago when we started, and Heather and Jen and others can maybe help me to remember, but I think we just started reaching out to other people that we knew in the Capitol or to do, this kind of advocacy work in this space. And we're like, hey, we want to put together a statewide coalition. We want to focus on state level issues. And we started inviting people to the table. But I'll ask some of my colleagues too who were there to chime in. Are there other pieces of this that you remember that I'm not recalling at the moment? You got it. Okay, very good. And like I said, the folks who are involved kind of changes every year, so I think you just have to keep kind of plugging it in all the spaces that you find yourself.
Thank you, Amber. Mm-hmm. Thank you so
Excellent.
much for your work.
Yep. Thank you.
It's wonderful to hear about the work happening in our host state. So thank you so much, Amber. We really appreciate your work and for you sharing with us. So our next presentation is led by Mary Jones, the President and CEO of Mental Health America of South Central Kansas. Mary, come on up. Mary is working with a group of panelists who are all fellow Bell Seal recipients to discuss workplace wellness. And joining her will be Julie Prater, Executive Director of MHA Lakeshore, Jill Kottmeyer, Director of Wellbeing at Endeavor Health, and Jim Poole, the Senior Director of Policy at NAMI Chicago.
I can't be up here alone, so panelists, please join. I'll keep a little clock going here, but let me know if there's, I don't want to mess with anyone's break time, so. Well, great. Good morning. As Alicia said, my name is Mary Jones. I'm President and CEO of Mental Health America of South Central Kansas, located in Wichita. I also serve on MHA's national board and as the affiliate relations chair, so I'm proud to be here this morning. I am filling in for Susie Craig, who could not be here this morning, and I'm clearly not Susie, but I thank MHA for the invitation to help moderate this session. Our organization is a 4-time Bell Seal winner, recognized at the platinum level, and so hopefully I'll be able to contribute a little bit to the great dialogue from our panelists here. I'm joined by Jill Kottmeyer, who is the Program Director of Wellbeing and Vitality for Endeavor Health, Jim Poole, the Senior Director of Policy. Oh, nope. Sorry. Okay, thank you. I didn't get that note. And Julie, our good colleague from Mental Health America, Lakeshore in Wisconsin. So, the part of this talking about advocacy and advocating for employee wellness is part of National's charge of understanding that those organizations who invest in their employees' well-being always fare better when it comes to employee satisfaction and well-being in the workplace reports. So we hope this conversation will help invite a little bit of that dialogue. I would like to share a couple of things in terms of what Mental Health America likes to share about workplace wellness. Is in this past year, 412 employers from 22 industries of all sizes with a collective reach of 4.19 million employees, received top recognition of the Mental Health America Bell Seal program for workplace mental health. All the recipients of the Bell Seal are required to show and demonstrate how feedback, the employees' feedback and decision-making is incorporated into their recognition. And it's interesting to note that 54% of those employers improved their overall well-being scores from the year previous. And I think that's a testament to the program itself, but also that driving thought behind the employers wanting to do better each time by their employee workforce. So I think those are really significant things. Maybe I'll share a little bit of more statistics in just a little bit, but I'd like to go ahead and turn to our panelists. Thank you for being here, and we're just going to start with talking a little bit about your organizations, each of you. In your work, how have worker rights and advocacy understood and or endorsed by decision makers in your organization? Or are they? Yeah, whoever would like to start. You want to go?
Sure. Good morning. So we are a 73-year-old nonprofit. We're one of 2 affiliates left in the state of Wisconsin, MHA Wisconsin. Martina's here, CEO. So decisions within our nonprofit, and we were at the beginning stages when the Bell Seal was being put together, and we were running through some pilot work. on the questions really comes down to the voice within our employees, also leadership, our board, but also those individuals that we serve. And it's really a holistic approach as we have changed over those 70+ years and how we show up, not only for the people that are doing the work within our organization, but also for those that we serve.
And I am from Endeavor Health. I'm Jill Kottmeyer. It's a hospital system in the Chicago area. There are 9 hospitals that have merged over the last 5 years. And if you can imagine what our healthcare workers have been dealing with since COVID, things changed a lot. And there was a need to support our team members in really intentional, different ways. And we're really grateful that our system really stepped up and listened and heard the needs of especially our bedside team members that were impacted so greatly by COVID, and now just the aftermath and just dealing with the complexities of patient care. And we now have a team of 8, small but mighty, to serve our 27,000 team members.
NAMI Chicago is a fairly large NAMI branch. I got you. NAMI Chicago we're about a team of about 130 folks and have a wellness unit that's really built around how do we elevate voice very, very easily, very quickly, and serve those who are serving lots of other people in their hardest and worst days. Knowing that our employee group is not different than those that we serve. We're going to have the same kind of experiences, same kind of struggles, same kind of victories. So we try to find a way to efficiently serve and lift up and create practice around everyone's needs.
And if you might just share a couple of notes each of like some of the how behind that. We'll get to some stories in just a little bit, but what are some of the ways in which you are uplifting your employees' voices?
So I am going to talk a little bit about our workplace programming and bringing in some of those partners. So we're in a very unique area in Wisconsin where we have a lot of companies that serve worldwide, manufacturing companies, and we work with all of them, Kohler companies, Sargento, just to name a few. And a few of the companies that I'm going to be talking about today have gone through looking at what their policy is based on employee feedback. And one of the comments that the companies gave me before I came was, policies are important, but culture change happens when employees know their voices matter. So one big company that has thousands of employees worldwide started screening through MHA screening, but also internal screening to find out what the pulse was around mental well-being. And what came out of that was they wanted more information. They wanted an employee resource group to drive change around mental health. And what came out of this over the last 6 years, and we were there at the beginning to build this ERG, was a leadership guide in the way that we're showing up, not only in a crisis, because these manufacturing companies are running 24 hours. What does that look like when someone's having a mental health crisis or they're having a need that's met at 3 o'clock in the morning? Who's there? What does leadership look like? This guide went worldwide, and it drives the way that they show up, not only in the way that they're responding, but also what they're providing for ongoing education, for suicide awareness, emotional agility for leadership. How are we having those crucial conversations, once again, at 3 o'clock in the morning when someone is needing someone there? And who are the ambassadors? It may not be a leader. It may be an individual that other employees are going to. How are we identifying them? How are we advocating for that to have a stronger platform? So that's one example.
Thanks, that was great. So we have 6 well-being support advisors on our team that are doing the direct support for all of our team members. And a lot of times those stories of need and change for policy change come through our well-being support advisors. And we are either supporting the team member to bring that if they are comfortable with that, or we are helping them use their voice and advocating for them on their behalf. But I come into this work a little bit differently because I'm a nurse and a thanatologist by trade. Everybody else on the team is an official mental health professional. And so I do a lot of advocacy in the grief space, and recently some of our team members have brought forth some concerns about our grief policies, specifically around miscarriage and the Child Extended Bereavement Leave Act that we have here in Illinois. And our policy for that is written for a child who has died by suicide or homicide. But within that policy, it simply states that the team member has to notify their manager within the first pay period if they're going to take that 12 weeks off. And if you know anybody whose child has died in any sort of fashion, let alone suicide or homicide, you can barely get out of bed those first 2 weeks, let alone make that decision that I need 12 weeks off. So we are currently, like literally in the process right now of taking her feedback and supporting her and elevating that to advocate to change that policy to better serve the needs of our bereaved team members.
It's an incredible example. Thanks for sharing that. I think that just speaks to what we learned doing this effort is authentic relationship is the way to understand what's going on and create a space where people can be real and vulnerable and believe that you're going to do something with that information. So our program can't be cordoned off into an office. It has to be socialized out as a cultural value, and meaning that if there's a great supervisor who sees a need, they have an easy pathway to elevate need and elevate solution and bring new ideas to the table. So really try to, we do information gathering through surveys, which I think a lot of people do, but that can't be the only static solution. It needs to be really pretty dynamic.
Yeah, thank you for that. And my next question, Jill, you almost touched on this in your example, but I'd like to hear from each of you a story of success where a worker or employee pushed back on a policy, and that's the title of it's our subject matter today. Is there a way that pushback changed policy, or another idea that just sprouted came from some of that work?
Go ahead.
So recently, we've been working with the company I spoke about in regards to suicide loss. So we've had a huge uptick within our community this year in suicides, and there was no debriefing model within their employee structure, also within their departments. And we have been highlighting the work that we're doing around community circling. We're working with this company right now to write it into policy that this is an offering that they would have when grief doesn't have to be suicide, but it could be something, back to your point, when something is happening with grief and loss within that department, that an offering for a gathering to connect and support those individuals that are going through that would be offered up.
So I touched on the one that we're actively in place of advocating for, but one that we've actually been successful with so far is changing the language around our bereavement leave, because it didn't specifically call out miscarriage or perinatal loss. And I was supporting a team member who was going through a miscarriage, and she had a vacation coming up and had not enough PTO to cover her miscarriage experience and her vacation. So she was coming into work actively miscarrying. And then after some digging, and she had a really strong voice and brought it to a lot of people, they said, well, it was covered, it just wasn't specifically called out in the policy. So now our policy specifically calls out miscarriage, whether that is the team member who's actively miscarrying, whether that's their partner or their husband, whatever that relationship looks like, that bereavement leave covers all of those spaces now, and it's specifically called out.
I would just add that I think we ask a lot of our leaders and our supervisors and managers It's not just technical that work anymore, it's emotional, it's supportive, it's meeting your employees who are bringing a lot of experiences from outside of the workplace. So something we hear in other workspaces too is it doesn't feel like there's support there. And so I shove it down or I bury it and kind of go by day. Well, what we need to do is equip those leaders to have the tools at their hands to be able to provide, to be supportive. We can't just promote people who are excellent at their job. We're promoting people who are good culture people and good at supporting their colleagues. And how do we create that skill set? So that's one of the things we think a lot about is how do we prepare leaders to do some really heavy kind of work and have access to resources that they need and make it just a little bit easier.
If I might kind of pick on you there a little bit, mental health, the Mind the Workplace report states that employers who encourage transparent communication and to develop fair and supportive practices consistently report higher overall team health. And these two best practices, though, are least commonly offered by employers. I heard you talking earlier about the socialization of the idea, right? And how have you worked through some of those cultural changes?
Worked is past tense, it's working.
Working.
So always,
Good note,
always
yes.
need to continue the conversation because of how dynamic everything is on the ground in our work, but also broader cultural. We really need to, our focus has been to onboard people into a culture. So anybody joining our organization, we're kind of giving them that permission to be real and authentic in a way that feels safe and right for them. And then we have to back that up with action that shows we can be a trusted partner to do that. So it really starts on day one and continues throughout all, the entire work experience with us.
Other thoughts from the other panelists there?
Yeah, because I think that was a mic drop moment from Ben about training our leaders to be able to help us change that culture because we can't do it alone. So similar to what Ben had shared, we are, our Wellbeing and Vitality team is there from day one. We are now embedded into all of our onboarding, whether it is new employee orientation, new nurse orientation, our nurse resident program, our physician and APP, New Start program, and then also within our emerging leaders and our leadership development. So a lot of education, but also echoing what Ben said, backing that up with action. So when people come to us for a leadership consult or for that support, we are really helping to create that culture and shift our leaders from just being simply task-oriented to doing their job to really caring for that whole human being.
Several years ago, our community health improvement plan through our community health assessment picked access and navigation as one of our key focus areas. And back to your comment, we're onboarding people into this culture. Sometimes culture needs to be demonstrated when it's not existing within that system. Our access and navigation program through many different partners and systems was partnered with the University of Wisconsin-Green Bay, and we put together a 12-week program where they are meeting in person at the beginning and the end and meeting those partners within their community and learning everything from emotional agility. How does 211 work? Who are the partners for the gatekeepers into systems? What does crisis look like? It's a whole approach to for a company to learn how to access services and how to support their employees through navigation. And this is an offering where we can demonstrate what good culture looks like by different partners being at the table. In addition, our organization partnered with Joe Feldman, who's here today, for Cover My Mental Health, and we put together a intro video on how to access services through insurance companies. This is offered now through all of the workplace partners that we work with, and this can be given to employees on how to maneuver a very complicated system.
Yeah, that's fantastic. And Julie, if you could just even comment that the transition from working with this in your own organization to helping other organizations implement these strategies?
Well, I always say we're the conveners, and we have to demonstrate in-house how this needs to look with other partners. And the landscape is there. Amber, back to your comment, advocacy is our superpower. If an employee is in a sick culture, how do we help them get a voice to change what it looks like within their own systems? And that's why we're here. We have to demonstrate it where we're living, working, and playing. And our community, our mission is to build mentally healthy communities. How can we do that in partnership with workplaces?
For each of you, I might hand it back before we open it up for Q&A for the room. What has been the most valuable lesson or thing that you've taken from this whole process of making sure that there's healthy workplace? Is there one thing, a few things?
27.
27 things.
I think communicating this in a repetitive way has been something that we're learning and refining our skill at, because there's an authentic desire to really take care of our community and make sure it's the best culture it can be. But that has to be communicated in a way that's effective, efficient. This is some new things that are being brought to the workplace, so we need to be nimble about how we make sure everybody is feeling that effort.
I think really leaning on all of the reports that MHA National has done to help build that platform. The partnerships are there for us to take. And those employees need us as their voice. If the statistic is showing X number of people are looking for work, how do we continue to help leaders understand if your employees are constantly having an eye out for a better culture, because that's what they're going for, we need to take that opportunity within our partnerships here.
And I would say, the ability to empower people and myself to use their voice to do that advocacy, but within that space, when you are talking to executive leaders who are at the top of the organization, you have to shift your language into speaking their language, right? I've worked in a lot of non-revenue generating spaces, so having that shift of what is this return for you when we are caring for our team members in this really intentional way? And how is that going to, unfortunately, they speak financials, but how is that going to impact the financial for them? So bridging the need and the desire and the necessity with their kind of perspective to help shift that and come to that common ground together.
Yeah, that understanding that the healthy workforce is healthy for everyone at all aspects of an organization. Thank you. I'd like to open it up, if we could, if there's any questions for our panelists today. I'm sure Alicia will bring a microphone around if needed.
Hi, thank you all for such a great panel. My name is Kaylin, and I'm curious what your thoughts are about during such trying times that we're in right now in terms of employee wellness. What success or what strategies do you see being most successful between EAPs, employee resource groups, all of those kind of things? Because I'm in a new role, heading internal comms, and I'm trying to cultivate a culture where people can feel more comfortable and at peace within the workplace. So do you guys see those kind of strategies working for the groups you work with?
You want to take this, Ben?
Yeah, there's a lot of stuff out there. There's a lot of people that are selling strategies that is sort of a one-size-fits-all approach. I think anything that's closest to community that is speaking to a direct request is usually the most impactful. Usually what we see requested within the workplace is how do we allow ourselves to take care of ourselves while we're at work, in addition to making work reasonable enough so that we can go home like kind of whole people and back to our communities. Certainly benefits are part of that conversation, We've usually steered away from EAP just because it's a little bit short-term and not always local and accessible. So we try to curate, like, what are the local service providers that we can have a relationship with and hand people off to.
Go ahead.
Okay. So there's two things that we have done within our organization, and the first was we started our own critical incident stress management team, so a crisis response team for when things are escalated or an event happens. We have that immediate response, and we now have 100 trained peer responders that work in that space and volunteer in that. But then also our well-being support advisor role, so it's kind of like having a person accessible most days for any sort of support, whether you are feeling really great and you're looking for some opportunity for growth, or you're in a crisis and you need that support. Because we also found that the EAP, a lot of people, it's short term, it's hard to reach out, but you have somebody in-house doing that support, it's really made a big impact.
I would piggyback on that. If you have individuals that are trained to respond in-house with a lived experience lens, years ago we were working with Patrick Hendry through MHA National, and he developed this whole curriculum. We trained through our Workplace Ambassadors program through this, and also anyone who is providing support groups through like their business resource group goes through our training to be able to respond to whatever those needs are from employees. And they have seen a bigger response, companies have, with somebody on site as their peer versus utilizing EAP.
Thank you all for those insights. I definitely will use those in my role.
Thank you. Any other questions, comments for our panelists? Okay, well, thank you very much to our panelists. I appreciate your insights today. Thank you.
Thank you so much, Mary. We really appreciate you moderating that panel, and I'm so excited that we were able to hear from Ben Frank, Julie Prater, and Jill Kottmeyer. I think it was exciting to hear about the Bell Seal from Bell Seal recipients. And I am going to remind you that as affiliates, you all have access to the Bell Seal. It is part of your affiliate benefits. So if you're interested in learning how to bring the Bell Seal certification to your organization, please let us know. Susie Craig is the right contact for that. So folks, thank you so much for your kind attention. We are now going to take a break, but before we do so, I wanted to tell you about our conference. Nope. I apologize, there's not a slide there, which is what I was just looking for. So I am currently reminding you that Mental Health America is going to be hosting our conference titled More Good Days Together in October this year. We'll be in DC the 8th and 9th. So please take a look at the card on your table, which includes a QR code, because you could just register right here and now to join us in DC for October. I am going to say go ahead for a break. We'll be back at 10 o'clock. Thank you very much. There I am.
We're never alone, no, no. sky, you know how I feel. Breeze drifting on by, you know how I feel. It's a new dawn, it's a new day. It's a new life for me, yeah. It's a new dawn, it's a new day. It's a new life for me. Ooh, 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 ooh. And I'm feeling good. Fish in the sea, you know how I feel. River running free, you know how I feel. Blossom on the tree, you know how I feel. It's a new dawn, it's a new day, it's a new life for me, and I'm feeling good. Dragonfly out in the sun, you know what I mean, don't you know? Butterflies all having fun, you know what I mean. Sleep in peace when day is done, that's what I mean. And this old world is a new world, and a bold world for me. Yeah, yeah. Stars, when you shine, you know how I feel. Scent of the pine, you know how I feel. Oh, freedom is mine, and I know how I feel. It's a new dawn, it's a new day, it's a new life for me.
You better think about what you're trying to do to me. Think, let your mind go, let yourself be free. Let's go back, let's go way on, way back when. I didn't even know you couldn't have been too much more than 10. I ain't no psychiatrist, I ain't no doctor with degrees, but it don't take too much time to see what you're doing to me. You better think about what you're trying to do to me, yeah. Let your mind go, let yourself be free. Oh, freedom, 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 oh, freedom, yeah, freedom, now freedom, 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 give me some freedom, oh, freedom, hey, think about it, think about it, ain't nothing you could ask, I could answer you what I want, but I was gonna change, but I'm not if you keep doing things I don't. You better think about what you're trying to do to me. Oh, think, let your mind go, let yourself be free. People walk around every day playing games, taking scores, trying to make other people lose their mind. Well, be careful you don't lose yours. Oh, think about what you're trying to do to me. Woo-hoo. Think, let your mind go, let yourself be free. You need me, and I need you. Without each other, ain't nothing even can do. Oh, think about it, baby. What you trying to do to me? Come on, baby. Think about it right now. Yeah, right now. Oh,
You're the place I go
listening to love songs, no one listens anymore. I thought of who you were beneath the clothing that you wore. I tried to tune you out, but you could never be ignored. You could never be ignored. And I'd rather be myself, although it's nervous and unsure. Looking for your shadow in the light beneath the door. And I want you all so badly. Oh, I've never wanted more. Oh, I've never wanted more. Tonight, tonight, you're the place I go to. Tonight, tonight, the face I tell it all to. Tonight, tonight, I just wanna hold you. Tonight, tonight. Tonight, tonight, is it too late to show you? Tonight, tonight, myself is who I owe you. Tonight, tonight, I can't do without you. Tonight, tonight, I wandered down the pathways that you paved inside my brain. It took me to a memory and a moment and a place. It shook me when it showed me I could never stay away. I could never stay away. And is this all you remember? Do your pictures the same? Do they live for you in color? Do they fit within the frame? And when you see the future, do you call me by your name? Do you call me by your name? Tonight, tonight, you're the place I go to. Tonight, tonight, the face I tell it all to. Tonight, tonight, I just wanna hold you. Tonight, tonight. Tonight, tonight, is it too late to show you? Tonight, tonight, myself is who I owe you. Tonight, tonight, I can't do without you. Tonight, tonight, how can I hold you? I give my all to. If you can't wait, then I can take just one more day. Tonight, tonight, you're the place I go to. Tonight, tonight, the face I tell it all to. Tonight, tonight, I just wanna hold you. Tonight, tonight, how can I
Hi, good afternoon, folks. I hope you enjoyed your break, and I would love it if you would come and settle. You know what? Actually, why don't you come up? Because it'll help. Hello, folks. right, everyone. Thank you so much for returning from break. We're going to go ahead and get started with our next presentation. Thank you so much. So our next presentation is led by Beth Markley, Executive Director of NAMI Idaho, with a panel of advocates who worked to push back against funding cuts that led to the worst case scenario, and who partnered with the media to elevate the consequences of those funding cuts. So in addition to Beth, we also have Laura Scurry, co-owner of Access Behavioral Health, and Rick Boyce, CEO of Mental Health Specialists in Pocatello. Thank you so much.
All right, thank you. We're really sad that we can't have our partner up here, Kyle from the Idaho Capital Sun. He couldn't travel to join us here today. My name is Beth Markley. I'm the Executive Director of NAMI Idaho. I also have an adult son who has schizoaffective disorder. So this is something that's close to my heart. And actually, I was not involved in mental health, the field of mental health at all, before taking on this role about 5 years ago. So my background is in nonprofit development. I also do have a history of 15 years as a host of a public policy program on Radio Boise, which is our local community radio station called Vital Idaho. So when this opportunity came up to talk to Rick and Laura about this issue, and I kind of inserted myself, even though I had not had anything to do with what they had worked on. But I'm so interested in this story, and I love public policy, and I'm kind of a junkie when it comes to policy issues, and this was something that was really important to Idaho. So I'm going to let Rick and Laura introduce themselves. But first, I want to share a little bit about the political landscape that we're talking about. If you're not familiar with Idaho, Mental Health America ranks Idaho consistently at or near the bottom in terms of access to mental health resources and prevalence of mental illness. And Idaho is a deeply red state and becoming redder. According to our Secretary of State's statistics, people are moving so-called blue state refugees. So Idaho has not always been as red. We are the home state of Cecil Andrus and Frank Church, after all. But it has become we are growing in record numbers, and it's becoming more and more conservative. And recently, since 2018, Idaho has experienced a $4.8 billion in tax cuts between federal and state. And that is a report from the Idaho Fiscal Policy Center. And at the end of the 2025 legislative session, our legislator passed and the governor signed the state's largest income tax cut. And we do have a constitutional mandate to balance the budget. And by the end of the fiscal year 2025, it was apparent that we were going to have a budget deficit in the state. So the governor called for, across the board, everything except for education, state agencies to cut their budgets by 3%. And this is despite having between $1.3 and $1.6 billion in the state's rainy day fund and it's one of the strongest rainy day funds in the nation, I think in the top 8 in the nation. So following that, the state's Medicaid contractor announced some devastating cuts to the Assertive Community Treatment Program and Peer Support Specialist programs in Idaho. So that kind of just sets the stage. I hope at the end of this that we can answer some questions, but in the meantime, I would like Laura and Rick to introduce themselves and talk a little bit about their work with the ACT program.
Well, hi everybody, my name is Rick Boyce. First of all, I should mention I'm from England, so if I speak funny, you can throw something at me, and if I need to repeat something, you're welcome to ask me to do so. I'll never be offended. So yeah, my name is Rick Boyce. I run a private clinic over in eastern Idaho called Mental Health Specialists. We see about 700 people a week, a whole variety of treatments, everything from counseling to med management to assertive community treatment we run now. And, well, let me see. My background, I've been living in this country for about 28 years. I've been working in the mental health field for 17, 18 years, and I am a clinical social worker, trained psychotherapist. And well, I think we'll get more into the legislative advocacy end of things, which has been a brand new thing for me. I've never wanted to be involved in that kind of thing. Kind of learned the hard way about a year ago when all of this started happening. So jumped in the deep end there, and this has been drinking out of a fire hose. So anyway, I'll tell you more about that.
Good morning. I'm Laura Scurry. I own Access Behavioral Health Services in Boise. Access is one of the largest outpatient programs in the state. So we have between 4,000 and 5,000 patients at any given time, providing 22 different services across the behavioral health spectrum. I've been practicing since 1992. So I had done a little bit of advocacy work at the rally level. Turns out that's not really how you get stuff done. And so when Rick and I decided we probably better step in after these cuts because we were concerned about patient safety, it was quite the education for us as well. We did successfully convince the legislature to restore two of the programs that they did cut in that sweep. The state not only did 3%, they actually went to 4% and then another $30 million on top of that coming out of behavioral health funding. So pretty catastrophic cuts. We did end the year with a lovely surplus. We are still gearing up to go get permanent funding for our ACT program. We were granted a year. We're pretty confident that it will come down as fully funded for the year, but we're going to have to advocate for the rest of this year to get that done.
So could you tell us a little bit, I'm sure everybody's familiar with the ACT program in this room, but could you talk a little bit about the scope of ACT in Idaho and a little bit about the history of that?
So ACT has been around 45 years. It's a very, very well-established program nationwide. Idaho had ACT services in place since the 80s, but it had been funded through the state, and so it was state employees providing state service. So it wasn't a fidelity-based model, but they did follow the ACT concepts as much as they could. When Idaho just reestablished a managed care model back in 2024, and as part of that model, they brought in, it was a full risk contract, then they brought in ACT, and they took everything that the state had been doing and privatized it out. So we were bidding, our state is set up regionally, so there's 7 regions. Each region was bidding for one ACT program. The expectation is that the ACT programs would be covering their entire regions. It's not actually physically possible in most rural areas, but that was the intent. And so this was the first time ACT had been privatized.
And to zoom out, press the button. And to zoom out a little bit further and go back a little bit further, assertive community treatment was set up as part of the deinstitutionalization movement. Back in the 60s, 70s, and prior, we had most of our severely mentally ill population hospitalized. With the invent of the antipsychotic medications, the antidepressant medications, and with the improvement in the therapy end of things, we were able to close down a lot of the hospitals and have a lot of people treated out in the communities much more effectively. There were a small population of individuals who were bouncing in and out of hospital still at that point. For context, in Idaho, there were about 10,000 people who were hospitalized under the original model there. And then immediately after that initial movement, they were down to about 600 or 800 people hospitalized. There were still about 200 people, maybe 300 people who were bouncing in and out of hospital regularly, though. And so assertive community treatment and a couple of other programs were put in place, sending hospital workers out into the communities to make sure people were taking medications regularly, checking on people that they were engaging in their communities, making sure that they were engaging with family, engaging with therapies. And by doing that, what it did was slow people down, cutting the rates of hospitalization and incarcerations by 50%. So it's a highly effective evidence-based program, like Laura was saying.
So I know that when word of the cuts came, it was October 31st because my phone started blowing up. What's going on with this? What is NAMI going to do about this? And I actually had no idea. But tell me, like I know you have a story about where you were when you heard about these cuts and your initial predictions. You want to talk about that, Laura?
I was on a tour bus in Ireland. Surrounded by Canadians and Germans. They are concerned. I came unhinged. The director of our MCO called me and said, hey, we just cut ACT and peer supports. And I was like, oh, sure, Dave. Cut the people with disabilities, Dave. Am I going to have to be the one that gets on there, Dave? And I'm yelling. And there's all these people in this tour bus like, whoa. So yes, it was a really dramatic moment. And then I called Rick and our group and said, we have a huge problem. The issue is that the way that they proposed the cut, they said, oh, we're going to unbundle it. Well, in my naive mind, I heard we're changing things, but you still have ACT. It took us another 2 weeks to figure out it's gone. It's completely gone. But we had to really drill down with both our MCO and the state. Because in my mind, when you tell me you're unbundling something, it's just changing how you pay it. No, it was completely gone. All the services and components of ACT that make ACT different from traditional services, gone. What we had left was traditional services, which, ironically, you have to, in Idaho, to get a prior authorization for ACT, you have to prove those didn't work.
So you realized really early that you were going to have to get involved, and you had said, Rick, that you had Laura, you had said your previous advocacy experience was rallies, but you knew that was not going to work. What was your initial thought in terms of and maybe Rick, you want to talk about getting involved with advocacy?
Well, I think our initial thought was that this couldn't possibly be intended. I mean. We drove over to Boise I drove over to Boise next day. Laura lives there. And we went and had a meeting with the directors of Medicaid and said, well, do you realize what the program is you just cut here? Because I think it was very obvious to anybody who's ever been around this program that there would be almost immediately people starting to die from this, people being hospitalized in record numbers. We'd be moving back to what was seen prior to the 1980s. Anybody who's familiar with this would be seeing this as something unconscionable. And what was shocking to us was that the directors of the programs were, I think they were very heartbroken themselves, but were very much recognizing what was happening and what was about to happen too.
So, and you, Laura, you had some dire predictions. You want to talk a little bit about that, and Rick, maybe about how you backed that up with your white paper?
So ACT, if you're familiar with the sort of community treatment, has some very, very, very direct outcomes. Decreased death. Because our ACT teams were only 18 months old, we kind of knew that because we were early in engagement for that level of treatment, we knew that as people started dropping off and we discontinued services, we knew that things were going to be bad. So we initially had gone to the press to tell them, hey, we need to notify our communities that this is happening. And I said there's going to be a death a month. We had 6 teams in the state serving 400 clients, 300 clients, and I was like, there's going to be a death a month. And it turned out we were exactly to the date with 1 death of an ACT member per month.
Whereas before it had been 1 death in the past 18 months, correct? Yeah. And Rick, you put together some substantial information that quantified the economics of this.
Yeah, one of the things that I guess has provided, so there's always been advocacy in Idaho at various levels for different kinds of programs. One thing we've never been in the position before, though, in disagreements with the Department of Health and Welfare, is in a position to have data that has been equivalent to them or in a better position than them. They've always come out and said, this is more expensive and here's our data, or this is, you're wrong about how this is going to affect things. And we've always walked in there and said, well, but you know that people are going to be hospitalized for this. You know that people are going to be, it's going to cost you more money than what you're paying because, when you kick people out of a reshab or when you kick people out of developmental services, it's going to cost you more money than X. What we did was we sat down and started pulling as much data as possible, whether that was coming from whatever the national sources that we could pull, university studies, pulling it all together, and pull together what turned into, over the course of a month or so, a full white paper, 200-page data-driven white paper, that looked at what does ACT do, and what can we predict based upon Idaho numbers, Idaho economics, and then using the national level data as applied to those numbers, and really look at what is this likely to do as far as hospitalization rates for Idaho, what is it going to do for incarceration rates for Idaho, what is it going to do for child protection rates, what is it going to do as far as how many people can work, how many people can, what is it going to do to the real, what is it going to do to the state economy as a whole? And that really put us in a different position for the first time, because when we were talking to legislators and they were turning around and talking to health and welfare for the first time was on the back foot trying to defend our numbers. And I think that was a very new experience for them, because they were not able to respond to those in real time. And they're coming back and saying for the first time, well, I don't think that's going to be the case. And they were in our normal position of trying to argue just off the cuff. It really kind of changed the entire argument for the first time.
And it gave you a really concrete talking point, which I remember, but maybe you could share the how much the cost in dollars of the ACT program versus not having it.
Yeah, so the cost of the ACT program, when you take out the federal matching funds and how much federal Medicaid contributes to Idaho, the cost to the state of Idaho is $4 million a year total for the entire state. What the white paper was able to show was the cost to Idaho of removing the ACT program, when you factor in police costs and attorney prosecutor costs and child protection costs and everything else factored in, plus hospitalization costs, everything you can think of there, $38 million would be the cost of removing the program versus $4 million in state taxpayer funds to continue the program. It was such a night and day difference. And then we showed them these numbers, and they said, well, we don't know if those numbers are real or not. And that's what we experienced working in a conservative state there.
So this is about leveraging the fourth estate. Do you want to talk a little bit about when did you bring the media in, and how did you you have a different terminology than I think I would use in terms of manipulating the media, but and I don't think that Kyle would appreciate that. But do you want to talk a little bit about leveraging that public sentiment and how you worked with the media on this?
Well, at the very beginning of this, we started reaching out to the media, and we I think we just threw out a wide net and spoke to anybody who would speak to us. As time continued, we started getting to know certain reporters better. And like you said, we got to know Kyle pretty well. I think Laura had worked with Kyle a little bit more before that. you mentioned the word manipulation. I think what we tried to do is really think about how do we. What was important was we tried to make sure that when we were telling the stories, we were rolling things out in such a way that, number one, we recognized that the newsrooms needed new stuff. This is not groundbreaking to anybody in this room, I recognize that. But the newsrooms needed new stories every single time. They needed new things to be reporting on. But the other part of it was that the audience, the newsrooms needed to be recognized. Okay, we're talking about small town newspapers here. We're not talking about the Wall Street Journal. We're not talking about the Chicago Tribune. When we're looking at readership numbers for small town newspapers, we realized that if we could show to the newsrooms that they were getting a high rate of 10 minutes left. If we had a high rate of turnaround for interest in the stories, we would be able to get more stories out of those cycles. So what we wanted to do was have, so we brought in more, hold on, how do I explain this quickly? What we tried to do was have as many of the people that we could commenting on those stories directly, creating our own cycles within those small towns. And what we realized was we could influence the perceptions of the media organizations themselves. In a small town, all we needed to do was have 100 comments, 100 likes, 100 responses, and we could generate our own cycles. We could get the newspapers themselves to continue feeding the next story over and over. And that turned into 70 or 80 news stories in a row.
In the meantime, we were working with, the goal was to get legislative attention, so we were escalating or de-escalating based on what was going on. Idaho's primaries are earlier than most folks, so we were surfing up to the primaries. The closer the primaries got, the more legislative attention that we got. We culminated with a story in the New York Times that made, in the news that gets delivered without the subscriptions, we made that grouping. So we started working with the New York Times in December. Mm-hmm. Our cuts happened December 1. Our final vote to fund it happened April 1st. So in that time, we were working with local press, but we were also surfing it so that we could get the New York Times story to come out. It came out the day before, or the day of the vote. And so we were able to escalate the attention or de-escalate the attention based on interest, just to keep things moving through so that we were relevant.
So at the same time, there was so the legislative session starts, and we've talked a little bit about the value of the relationships that you were cultivating. You want to talk a little bit about that process and also some of the mistakes that you saw being made with regard to building those relationships?
So I think out of our group, I had the most experience in working with legislators. I might have met with 5 in my career. So we started out, it turned into an investment of time. We were in the Capitol 5 days a week. We were in the hallways where they meet, congregate, move around all day. So we started out learning about our legislators. We had some folks, we have a group, a small coalition of ACT owners, that we had some contacts. They knew them, they could reach out and say, hey, do you know about this? So we had 3 or 4 that we had their attention, and we had their buy-in, they wanted to help us. But developing relationships with our health and welfare committees and our JFAC was Rick and I, and we didn't know how to do that. We didn't even know we had to. So we just started with the ones that we knew, developed relationships. You have to get to know them. What are they interested in? What kind of people are they? Why are they in the legislature? This is basically a volunteer position in Idaho where you give up your job for 4 months and then come back. What motivated them to be there? What was their platform? Starting to really get to know them on a one by one, and we talked to hundreds. And we would just set up appointments, wander the halls, running into people, developing those one-to-one relationships so that when I went into, we have nicknames for some of them, but like Tanner 14B, we knew he's financially motivated. He does not care about people dying. His wife does, but he doesn't. And so really getting to know as much as we could individually so that we could have one-to-one conversations about what they're interested in, and we knew not to go in there fighting. We didn't go in there swinging. We didn't go in and tell them they were wrong. We said, we need to partner with you to fix this. You know, where are you willing to start the process? Some of them, if we went in and said people are gonna die, they would be like, oh my gosh. If we went in and said this is gonna make you look bad, they'd be like, oh my gosh. If this is gonna come, if we would figure them out one by one by just getting to know them as actual people. What are their values? What's important to them?
I wonder if you could just share a little bit about some of the surprising alliances that you built. I'm talking about like endorsements, people who had maybe some clout, some standing with our legislators.
So Idaho, as we mentioned, is a very, very conservative state. The other thing to note is that we're not CCBHC motivated. Idaho is back in the 90s. With private providers. We're all just under contract with our MCO. We don't have big groups of clout. It's not a lot of federal funding coming in, just the match dollars. And like Wild Wild West style. Just go back 25 years. So interesting alliances. We learned about our legislators one at a time. We developed relationships with them, and then as we got to know them, Rick tells a really funny story about one of our legislators actually educating other legislators about our cause while not voting for it. She didn't vote for it. She was one of the 11 votes that we did not get out of the 52 that we did. But she had Rick by the arm in the hallway one day educating another legislator about the cause. The whole time did not vote for it. Said, oh, I can't vote for that. Don't have permission. So those relationships, we had a bet, an inside bet, that one of our legislators would never even discuss this with us. I now send cookies to Rick every month because that legislator who was never going to vote for us, who was the co-chair of JFAC, pushed our legislation through, our funding through, the last day of the last hour of the last moment. He pulled it off of somebody's desk because that legislator was out, and co-sponsored it through to the end, to the finish line, so that we were funded. So those relationships, totally different.
But I think where that the legislator you're talking about there, one of the big problems that he was having with it. So this is a very conservative individual. His biggest. He came in and had a lot of resistance there. We thought that they were going to be snapping around once we started seeing deaths occurring. And what ended up happening was we started seeing movement when, yes, we started seeing changes in opinion because we were up there and telling the story day by day by day, and we were seeing deaths happening in real time. And we were telling the stories in real time. We were spending so much time in the Capitol that people were getting, people were knowing us, and as we were saying, yes, there's been another death, yes, there's been another death, it was influencing them. But we were seeing the economics playing out in real time as well. And he being part of the Joint Finance Committee, we were seeing he was talking about how, yes, the financial side was playing out as predicted by the white paper. And I think that was such a key part of the whole story, was that we'd predicted the outcomes. Laura had been predicting, yes, we're going to be seeing those deaths every single month. The white paper had been predicting that we're going to be seeing this many people hospitalized, we're going to be seeing many people going to jail. He spoke about on the House floor that we need to put this program back in place because the state is spending so much money at this point on hospitalizations that we need to put this back in place.
And so I don't know if you caught that. Now Laura owes Rick cookies every month for the rest of his life because this was a legislator that is not a softie. As a matter of fact, he's been trying to dismantle the organization that's the fiscal sponsor of our 988 program. He's kind of anti-woke. Not kind of, very much so. But this is the person who pushed the bill on the floor. So you did at one point have some lawsuits going on. You want to talk a little bit about those using those as a tool? You knew that those were not necessarily going to be successful in and of themselves.
So early on, we kind of did a strategy, like a war session. And one of the things that we realized was that these cuts went directly against Olmstead and ADA. So we searched out attorneys. We were testifying at legislative hearings that were pre-session for us. At the same time, we were hiring attorneys to sue the state in hopes that we could get their attention. Lawsuits in Idaho are kind of a big deal because they're expensive. Our Attorney General has had some turnover in their office. And so we realized that we needed to show them how serious we were. So our ACT Coalition, this is a group of people who own agencies that have the ACT teams, had been given the bids. We all came together, pooled our 12 cents, because we're Medicaid providers, and hired the best attorneys that we could find, knowing we probably aren't going to win this, but letting them know that they are legally threatened at a lot of levels, which again gets that legislative attention, but it also really helped us get stakeholder attention. So we had support from the Idaho Sheriff's Association. We had the county commissioners from multiple cities. We had mayors from multiple cities going, hey, they just cut my police force by 3%, and now I have to take on your job. And so we had some really high-end support, coming out of the cities and the sheriffs and the police and all the different stakeholder groups once the lawsuits came in.
So you've had a reprieve here for a year. What does the coming session look like, do you think? Yeah, I mean, it has been funded, but only as an emergency stopgap measure.
So the next year is going to be interesting. I think at this point we've raised a lot of awareness around this topic, and it has become a little bit of a little bit radioactive. So fingers crossed that this is something that they don't want to touch again. However, we have funding in place that is, like you said, it's a one-year funding stopgap. And what we are hoping to do is sneak this in. We're hoping to make sure that it's in the official Medicaid budget that is just going to be battened away and taken care of. However, we're also planning on moving back over in Boise and advocating this at every level as long as we need to.
We do have a piece of legislation that's written. They held it out of committee because it wasn't funded. We're now funded. Our goal is to get a line item on the governor's budget and on health and welfare's budget, so that when they go to reconciliation, we'll be on both, so that it'll be harder for them to find and cut twice.
I also want to just point out, 5 minutes and then Q&A. No, I mean, you got the funding reprieve for a year, but the program has suffered some pretty significant setbacks as a result of this. Do you want to talk a little bit about where it is now?
Nobody wants to pay for this. Actually, literally at 6 o'clock this morning, I was on my emails. So the MCOs, we got it back. The state was very supportive. Medicaid was like, go, baby, go. So we proceeded without startup funding to put our teams back together. Teams can typically consist of 8 to 10 providers. They're all very, very high end. And we had to go hunt our clients down. So the intention was we were all going to start with we were going to go find the clients that had been discharged from services, which really we were all just doing pro bono services, trying to hold on to. We put our teams back together. We started hunting clients. We immediately started getting pushback from the MCOs. The payers wanted to change the prior authorization process. They wanted to move away from a fidelity model into something that we all agreed on. They wanted to set up we have 3 MCOs in Idaho based on their individual insurance process, if you're MMCP or if you're a dual or versus just straight Medicaid. This morning, I have one of the Medicare-Medicaid crossover people trying to redefine what mental illness is. We can't get prior authorizations done, they can't agree on a length of time, they can't agree on a diagnostic process, they can't agree on review processes, and we don't have a declared fidelity model to follow for adherence purposes. So it's the MCOs don't want to pay for this. It's expensive. It doesn't serve a bazillion people. They wiped out all of our higher acuity. They're now gone after our lower acuity, making it all required to be prior authorized. So they really only want the walking well, and that's not what Idaho's carved out. Idaho carved out to SPMI versus the SMI population. So it's a continued battle. I think we're gonna have to sue them.
I think one statistic I heard from, we have 7 regions in Idaho, and Region 4 is right now approving between 3 and 4 readmittance to the program every month, and they have a waiting list of over 75. So, and you're in 4, yeah. So it's not like everything's hunky-dory. We've got all 400 people back. We're working to get them all back. And in the meantime, the deaths are still occurring at the rate of a person a month, which is devastating. So anything do you want to say before we get questions and answers to wrap up? So thank you. Does anyone have any questions for us? Please.
Hi, thanks for your sharing from Idaho. I had a question for Rick. You mentioned the economic case that you described of a little bit of money, relatively speaking, in prevention, early intervention leads to huge savings. And I'm wondering if that information has been analyzed and maybe published, because I think that's part of a really important body of resource that could be used not just in Idaho but in other places. Thank you.
Yeah, so the white paper was published on the Idaho Association of Community Providers website. IACP, if you Google Idaho Association of Community Providers, you'll find it on there under mental health. There's a drop down at the top. So that has not been fully peer reviewed or anything else, but it's the white paper is published on there.
We did have our data looked at by Northwest Nazarene University. They did confirm that all of our data points and all of our citations were in fact legit, which was not a full peer review, just there wasn't time. But we were reviewed through their process to make sure that we were university standard.
Thank you for sharing this anecdote, this whole story, but also this specific instance. I respect the wager and the ongoing cookie debt, but I am very interested in knowing if you have a guess or have some, things you've heard in the interim as to why the legislator that is very anti-woke, as you've described, what made a difference for them?
His wife. No. What? She was in the room. She's really nice. I think Tanner comes across as he's a little more woke than he wants to be. He's not a bad person. And I think that the money really made sense. When we sent out the white paper, we sent it out a couple of times in a couple different ways, just to give people options on how many pages they want to read. And Tanner opened that thing at 1 o'clock in the morning and then proceeded to open it multiple times. And so really watching if you're sending out, really specific letters, make sure you're using one of those programs, MailChimp, that will tell you, because tracking that data and understanding their engagement helped us send more information out to them or less.
The data was also drilled down. We've talked so far about it being kind of statewide data. It also drilled down to the homeowner level. So it looked down even down to an individual homeowner. In order to pay property taxes, it was going to be $600 per household for an average household size in property tax to be able to pay the increase in kind of local jails and local hospitals and things like that. So I think when he was looking at those numbers, I think that had a big effect on him personally.
I will note that Idaho, our legislators are highly driven by a particular public policy think tank that's very libertarian in nature, and they grade our legislators on fiscal policy, right? And so anything that has a fiscal note to it, and it generally speaking is immediate fiscal impact. Anything that has any kind of fiscal effect is going to be graded down. And so there are legislators that live or die by this grade that they get from the Idaho Freedom Foundation. And that's what drives them. So longer term financial impact is going to not be as important to them as like the immediate term. So they're looking very closely at those dollars and how they impact them and how it's going to impact their next election.
But longer term, what we're trying to do is get some kind of bill in place. We have a bill written, like Laura was saying, a bill in place that would protect acts in line with other emergency services, essentially. Because this is a program that's been around for 40 years that provides a service to actually keep people out of hospitals at a level that no other Medicaid program in Idaho does. But the barrier that we ran into was that it had a fiscal note at all. And the Freedom Foundation will not allow notes to go through like that, or bills to go through with a fiscal note. And it was dead on arrival because of that.
We did have some movement during our primaries. So the Freedom Foundation lost, they call themselves the Great Eight, and now there's only 3. So I'll let you guys math that out. 5 of their folks lost their seats. And so I think we're going to see some differences there where hopefully the Freedom Foundation learns to math a little bit differently as far as value goes.
I'm so impressed by how you've mobilized and partnered with each other. And prior to this happening, this is January of what year? 2025 that this?
6. So the cuts were made in October of 25.
Right.
Yeah.
So what was the relationship before this happened? Because the amount that you've just described is incredibly impressive, the resources that you've been able to pull together. So could you just, for those of us who are just really from more rural places and may not have infrastructure, just describe that a little bit, please.
So I'm a founding member of one of our associations in Idaho. It's one of the primary behavioral health provider associations. It's called the Idaho Association of Community Providers. And I'm one of the founding members from back in like 1999. So Rick had just got voluntold onto the executive board of that. Still why I'm giving him cookies. And so we had been partnered on legislative awareness for about 2 years. These ACT teams, the learning curve on setting up, like you can watch an ACT team all day, but unless you're putting one together, they are highly technical. And Idaho had never privatized it. So we worked really closely together just to put our teams together. We had a lot of collaboration with each other. So between the association business that we were doing and the fact that we were both setting up our own teams in our own areas, Rick lives across the state from me. And we put together this little coalition. And so between the association components and just our own time spent calling each other on the phone going, do you know what this is? Or how are we going to solve this? Or what is this? Or how many times is this? I can't do math and Rick can, so I have to be super nice to him all the time because he does help me with my math.
All right. Well, thanks for allowing us to come and share this story with you. Really appreciate it.
Thank you so much, folks. I really appreciate your work. And I just want to remind folks, like, these were not people who thought of themselves as advocates, right? This work inspired them to be so. And I know that that's important to all of us because to be inspired to do this work is vital to be able to keep doing this work. So I'm so glad to be able to platform inspiring advocates for all of you. So, continuing on the theme of inspiring advocates, I would like to bring up our next presentation. And that presentation is going to be led by Tim Clement, Vice President of Federal Government Affairs here at Mental Health America. And our panelists, we're going to share some exciting coalition work out of Colorado that successfully pushed back against Medicaid policy. So I'm inviting Wendy Buxton-Andrade, the Vice President of Government Affairs at Mental Health Colorado, Brock Herzberg, a partner at Capital Focus, LLC, and Shannon Groppenbacher, Healthcare Policy and Advocacy Director at AZ Bio. Please join us.
I'll sit here, I guess. Hey, you guys can just slide the mics down. All right, well, thank you, Alicia, and it's good to see everyone. I'm glad you could make it here, even with the tough weather conditions from yesterday. I was very lucky to just narrowly avoid those thunderstorms by about 10 minutes on my plane. But yeah, so we're here to talk about policies related to prior authorization, step therapy, state Medicaid, preferred drug lists, and what I'll do first is just sort of set the table with what we're talking about. Now I look around the room and I see a lot of you are very savvy individuals who understand the ins and outs of preferred drug lists, prior authorization, step therapy, but I will hijack this panel for just a minute to give an Advocacy 101 tip. You're never doing anyone a disservice by speaking about things in plain English and plain terms. So that's what I apologize if I seem like I'm insulting your intelligence by explaining what a preferred drug list is, what prior authorization is, what step therapy is, but I think it is important to do so just in case you're not familiar with what those terms mean. So a preferred drug list is kind of what it sounds like for a state Medicaid program. They have a list of medications that are essentially and it applies to fee-for-service Medicaid, but also usually most states require the state's Medicaid managed care organizations also to adopt at least the preferred drug list in terms of how they cover prescription drugs. So what it means is if a medication is on the preferred drug list, that means that a Medicaid enrollee basically can get that medication with no restrictions, no limitations, no barriers to getting the medication. Now, sometimes those medications are very cheap generic medications, and that's why they're on the preferred drug list. But other times, and frequently, they are brand name medications where the manufacturer might have some sort of rebate agreement with the state. And so that's why it might be on it. So when we're talking, let's say, antipsychotics, I'm not just picking favorites here or anything like that, but you might have a medication like, say, Seroquel is on the preferred drug list. And so if individuals need access to an antipsychotic medication, they can get Seroquel with no problems. But if they want Abilify, another medication, or any other antipsychotic medication, they're going to have to go through some sort of process to get access to that medication. So oftentimes the two main things that are put in place if a medication's not on the preferred drug list are prior authorization and step therapy. I think prior authorization is a pretty simple concept. You can't get the medication, access to the medication without going through some sort of a process with the state or the Medicaid managed care organization to get approval for that medication that is not on the preferred drug list. In other words, you have to go through a barrier, a hurdle, and oftentimes that barrier is going to be pretty significant and you're not going to get that approval because they want you to use the medications on the preferred drug list. Another even more common tactic is step therapy. What that means is you can get access to that medication that's not on the preferred drug list, but you're going to have to go through some steps. In other words, you're going to have to try at least one, sometimes, as was the case in Colorado, and we'll talk about that in a minute, maybe 2 medications. So you'll have to try, so if we're talking an antipsychotic that's on the preferred drug list, you'll have to try not 1, but 2 other antipsychotics and fail with those antipsychotics before you can get approval to the medication that's not on the preferred drug list. So that's something that often when we think about that, what does failure look like for an individual who's prescribed an antipsychotic? What does that mean? I think for a lot of the folks in the room, we know that means something pretty awful, usually. And if it's not awful, it's something that's certainly not pleasant. So failure in the term, and that's often another term people use for step therapy, is fail first. You have to fail first these medications before you've given access to the other one. Failure to psoriasis medication, I'm not downplaying the severity of anyone who has psoriasis and if you have a bad reaction to a medication, but that's not the same as failure of an antipsychotic. So if you have schizophrenia or any other psychotic disorder and you take a medication and you fail on that medication, that often leads to very negative outcomes, both health outcomes, societal outcomes, potential criminal justice outcomes. So it's something that failure on an antipsychotic, especially if you have to fail more than one to get to the one that you need, your prescriber thinks you should have, could be not just bad outcomes, it could lead to death. So it's something that's a very serious stakes, and why we as an organization always advocate for broad access of all types of particularly antipsychotics on a preferred drug list within a state's Medicaid program. Now, we know oftentimes what states will do with the preferred drug list. They're not going to include every medication, and they don't just have preferred drug lists just to be inconvenient. They do it to try to, and we'll talk about costs in a little bit, but they try to do it to keep costs manageable. And for a lot of times that does make sense, but there are some instances with, for example, antipsychotic medications where maybe it's not really actually doing something that saves costs. It might even be driving costs. So in Colorado in 2024, they passed SB 24-110. And I won't go to the ins and outs and the weeds of the bill, but basically what it does is it reduces those prior authorization and step therapy barriers to antipsychotic medications that are not on the preferred drug list. And also, essentially, when it comes to some of those fail first requirements or step therapy requirements, it lowers the threshold from 2 to 1. And then also, if you've already been on a medication and stable, before you've joined that particular the Medicaid program, you don't have to go through a prior authorization or step therapy. So it is something that it was definitely a significant step in making sure that people didn't have to go through those barriers in Colorado when they're trying to get access to antipsychotics. And it's also very narrowly tailored to antipsychotics, which is something that I think is some of the folks will talk through. Having things very tailored to a specific type of medication or type of condition, that can often help in the advocacy push. So the first question I have for the panelists is, so a successful coalition has many different stakeholders to bring many different perspectives and values and different points of reasoning. And that's part of the value of having a coalition, is so you can have those different voices, and also you can get those strength in numbers. I just want to ask each of you, what values and perspective did you bring to the coalition working on SB 24-110?
Let's see if this works. Since I have disclosed, I was not there when this went through. I've only been with Mental Health Colorado for the last 2 years. Actually, I was on the other side. I was a county commissioner before that and worked with many of these people that signed on to this bill. When we started talking to people and finding out the history of this, we found out that providers as well as advocates had to come together, had to come to the table. But it was educating the representatives and the senators that really made the difference. They'd been working on this for probably 20 years, trying to get people to the table. And people didn't understand what it meant. So they had to put people before politics, which is hard in the current state of affairs for our whole nation. And so they really broke this down and got better at talking the language between Republicans and Democrats. A lot of times when you look at it, the Republicans are very worried about money. The Democrats are very worried about people. And bringing those both together, and the bill actually calls those things out. And so they brought both to the table. They talked about how this was going to save money in the long run.
and decriminalize mental health conditions. And so I think that that was one of the biggest things, is bringing them to the table and talking the talk between what resonated with the Republicans and what resonated with the Democrats, to get them to understand. And two of our sponsors actually have had to defend this last year, because Senator Kirkmeyer as well as Senator Amable are both on our joint budget committee. So they're defending this now when they look through our budget and making sure that this bill actually stays, even though it does have a fiscal note, it actually has a savings behind it, so.
So, is it on? Is this one on? Yeah, okay. So like Wendy, I was not there in 2024 either when this bill was passed. And I also want to provide a little bit of clarification. Although I do sit on the board of Arizona Bioindustry, and my role and capacity in this was in my work with Johnson & Johnson. I work for Johnson & Johnson, and really when Tim asked the question about, what value do you bring? In my role, I work with the patient organizations like Mental Health America, NAMI, Mad Moms, but I also work with the professional side of the organization, so the Colorado Psychiatric Society. And really my job is to raise the issue to them, to vet really, are they interested in engaging on this issue and taking it forward on behalf of really protecting what was passed in 2024 to ensure that, patients do have appropriate access to care. So that's kind of the other side of it that I bring. I don't work at the legislative level, but more the grassroots level with the patient organizations and the provider societies, trying to build the coalitions of getting them all to move the issue forward.
Not.
I think you have to hold it.
Oh, okay. Thank you, and my name is Brock Herzberg, and I'm here as a consultant, which I think most of you would know as, it's just a nice way of saying I'm a contract lobbyist that spends time at our General Assembly, and I do both state and federal work in Colorado, but I'm there 120 days. My book of business ranges from agriculture to healthcare to gambling, water issues, so it runs a gamut of things that I talk to all 100 of our legislators. And I know it's not a very popular term. I think it's an easy vilified one, that I am a hired consultant. But what I bring to the table, and I think what the government affairs side brings to this conversation, is those relationships that we have, or that I have in this instance, and I was also down there on behalf of Johnson & Johnson, that I can talk to these people, because I think some of what Wendy said earlier, the perception that Republicans only care about money and Democrats only care about people, you need to be able to cut through that, because those are very broad statements that don't always ring true. And I think with what Wendy said about Senator Kirkmeyer and Senator Amable, you had two people there, one Democrat, one Republican, that may have come at it from a financial standpoint and more of a, I'm doing this on an emotional standpoint, but how do we prepare them for the arguments that they are going to hear? And I think part of what I could bring to a conversation like this when we were going through the original bill, and then what we just went through in 2026 in defending it, was, and I don't think we're any different than Idaho or any other state that you've heard, there's just no extra money. We also have a rainy day fund that we kept saying, we'll take some of it, but Colorado has a constitutional obligation to keep a certain portion in there, and if you go down below that, then you've got to start scrambling to look. But what you can bring to the table from that conversation is how to best prepare legislators, knowing that especially in healthcare, which is in Colorado, and I'm sure it's very similar across the country, healthcare is the largest portion of our budget, and it's not stabilizing, it is continuing to grow. And when you're looking at a relatively small population like people who are might be on some of these antipsychotic drugs, especially compared to some of the others, you really have to be able to say, what can we give to these legislators that will prepare them for the fight that they are going to have to defend this, so they are not cutting it, and that they can go back to their respective parties and caucuses and say, here's why I did what I did, and here's why I need you backing me up on this, and here's why I need help defending it. So I come from the advocacy side, but just strictly that kind of, people kind of like, ugh. But I'm in the Capitol every day, all day, and it's those relationships that I can partner with the advocacy organizations to say, here's how you tailor your letters when you're talking to your advocates that are going to be talking to these legislators, really hit on some of these key points. So that's what we hope on the government affairs side to be able to bring.
Yeah, I think that's a great, all three just presented a great encapsulation of how coalitions and advocacy work in general when done effectively. Is you have different stakeholders who play different roles, and all of them are important, and you're not going to generally succeed if you don't have some amount of weight pulling down on each one. You can't just have the hired contract lobbyists. Occasionally that can work, but and you can't just have the grassroots push, and you can't just have the advocacy organization that informs and advocates. You have to have all of those things working together. Another question I have, and we've touched on this a little bit, and we talk about preferred drug lists as being a way to contain costs. In terms of SB 24-110, but just generally speaking, when it comes to, say, prior authorization for an antipsychotic medication, what arguments or data did you find effective in convincing legislators and other stakeholders that removing prior authorization actually might even reduce costs, not increase costs?
I think one thing that I really noticed with this is the sell that they had to the legislators, that not changing people's medication and giving them the medication that already works ultimately saves money down the road. Actually, in the act, they talk about, it keeps people out of the criminal justice system. So there's cost savings there. Access to care, it reduces hospitalization by 23% for inpatient costs. I mean, all the way through here, they talked about facts to solve by letting people get on the correct medication from the very start, stuff that is working for them. And that's what it actually costs the state more to have trial and error on medication than it does to get them on the correct, and maybe more expensive medication, but to get them on the correct and take down barriers to care.
So when I come to Wendy, or when I go to NAMI or to the Psychiatric Society, I always present the issue from the standpoint of protecting the autonomy of that doctor-patient relationship or healthcare provider-patient relationship. Because we know often in mental health, if we get the patient on the right medication the first time and we use shared decision-making, determining side effect profile and efficacy and what's right for the patient, more times than not, we get a better outcome. So in my conversations, it's not so much about data, but recognizing that in mental health, that's really how decisions are made. And even in some of my conversations, recognizing the fiscal situation that was in the state. I think the JVC report was 13 pages of proposed cuts, wasn't it? I tried to go back and find how long it was. But it was humbling, right, to bring my issue forward in light of the situation in the state where so many things were going to potentially be cut, but really acknowledging that the way that the law was written, it did have a component of fiscal responsibility in it, stating that the patient, the provider could attest to the fact that the patient had tried one preferred, but now allow that provider to make the right choice for the patient. So there was still that component of fiscal responsibility that was so smartly, like the way Wendy says, that the law was written and they put the justifications of the facts in the law, but there was that. And often at times in my conversations, I would bring that forward in light of the current situation of fiscally what was going on in the state.
Yeah, I don't really have much to add to that, and I agree with all of it. One of the things that, we've, and not just myself that's a pharmaceutical or healthcare lobbyist, one of the things that we've started to say is these terms like prior authorization and step therapy are kind of code words for healthcare denial. Like they are just barriers to you getting access to what you may already be on or what you may be told is something that could help you. And that's again, it's aggressive and it's ambitious to say, let's cut through the BS here. All you're being told is this is just another hoop that you want that patient, not Johnson & Johnson, not Mental Health America. It's Brock Herzberg personally who's on these drugs. That's a hoop you're wanting him to jump through just so you might save a little bit of money. And I think to Shannon's point, with our joint budget committee, which there's 6 people on that committee, but they're probably 6 of the most powerful people in our General Assembly. What it was showing was these weren't just program-saving changes. You were putting a lot of kind of hope, if you will, on putting prior author step therapy, that this could help solve the budget crisis. It just wasn't do it. And that's what we started shifting our rhetoric to. We get there's a budget problem. You are increasing people's problems with getting health care. And we just started saying every time you hear prior authorization, it's access denial. And that really did resonate, especially across the aisle. That was fairly bipartisan, because people could equate that to, oh yeah, I have an aunt, a brother, a cousin, a friend who's gone through this, and just started saying prior authorization is access denial. It's not a great way, well, in my mind it is because it works, but it's a kind of hand-to-hand combat of they're using prior authorization to save money. We think they're using it for this way. So it's the budget conversation, I think, in Colorado ended up being a little bit, especially moving forward to this year, kind of a stop. We're not budgeting the balance based on prior authorization. Just stop bringing it up. And I think part of that is some of the intentional wording that we were using around 110 and what patients thought that this could do to them, and it helped in that budget conversation as well.
Well, Brock, that's a great segue into the next question, which I think you've already touched on, but we'll just put the question out there plainly. Besides the cost argument, were any other arguments, as you've already sort of hinted, related to health outcomes, social ills avoided, that were effective beyond just the budgetary dollars and cents? And it sounds like it is, but were those other arguments, did they resonate, did they land, did they help carry the day?
Yeah, and I'll start that one. Our joint budget committee, when they're going through this, it's a very open process. The public can come in and engage with them. Certain times they set aside entire blocks of a day, 2 days, where they say we're taking only public comment. They can do it throughout the process as well. You saw people showing up and waiting to give public comment until 2 a.m. These are people with their children with them, or their child, or somebody that they are taking care of is at home, and they are sitting there to wait and say, here is what the real world impact of this means to me as a parent, as a patient, as a caregiver. And that was one of the things that I really hammered on is, especially in this space, the advocacy community is great showing up, especially when these types of things come up on like HIV drugs. Antipsychotic, it's a little bit different because it's a different patient community, and they deal with different sets of challenges and not one better or worse than the other. But asking these people, sit there, and you may have to sit there for 6, 7, 8 hours. I know it's a challenge. It was so important to them. That resonated with the legislators, seeing them sit in that small committee room for 8 hours just to get up here and say, here is what prior authorization means to my child, my husband, whomever. Those in my mind, and that was some of the political advice I was giving on a daily basis, is this has to be personal, and that will resonate.
I think really the only thing I have to add on that is, I think the first hearing was in the beginning of the year, and so I went to the organizations locally and said, you know, I work across multiple states, and so in the state of Colorado, the opportunity for the public to engage in that is pretty significant and helpful. And so I went to the organizations like Mad Moms in the state, and one of the moms was there, right, to tell her story about what access to antipsychotic therapy means. And so I think it's that human side, really, different, like what Brock says, versus kind of more of a fiscal impact in some situations, but you bring that human story to it, and it does bring light, I think, to the situation.
I don't have much to add there. We do have a brainwave that people that with lived experience signs up through our website, and we do call to actions all the time through newsletters, and as things go through the legislative session, just like this bill, any bill we have, if you've got lived experience you can relate to a bill, we ask them to call into action. Send your legislators information about your lived experience. Show up to testify. Here's the times. And it made a difference this last year. I know when it was going through the JBC, I text as they're setting their JBC. I text a couple of our senators that are setting up, they're making the decision, and saying, you know, as we're listening to what somebody's saying, this is another reason why, and texting them so they're reading their phones as they're setting up there, and just telling them, you know, this is somebody's life. This is not a medication. This is somebody's life. It affects their living, their well-being outside of everything, and it affects the families. It affects the communities, and they hear us.
So that leads into another question. So what was the toughest or most sustained pushback or that you experienced in this effort? In other words, trying to oppose, you know, the efforts to pass the bill. I mean, this isn't necessarily a traditional prescription drug consumer advocacy piece in that it's the state preferred drug list. It's not necessarily directly implicating the insurance companies and their, you know, formularies and so forth. So what was the strongest pushback that you encountered during the whole process?
I would say, and I think this would probably ring true across the country on bills like this. It's automatically branded as this is pharmaceutical self-serving, and if you scratch beneath the surface, this is only those pharmaceuticals. They don't care about the patients. That maybe 10 years ago was probably a good way to do issues like this. I think now, because of organizations like NAMI and Advocacy, that has really changed the tenor of the conversation, because to Wendy's point, you have people coming there with their real world lived experiences, but that is probably, at least in my mind, one of the highest hurdles to clear. And then it does come, depending on the state of your state's fiscal situation. I mean, you do have to realize that is part of the conversation. But I truly think that at least the last couple of years, it's been this, it's a self-serving industry. But I think the advocacy through NAMI and other organizations has really helped throw some cold water on that. But from my standpoint, that's probably where the biggest challenges come from.
I would say just for me, it was in 13 pages of proposed cuts, how do I get my issue I'm bringing forward to the top of the organization's list? Because there's only so much political capital you have, right? And are they going to take my issue forward? And it was really, I mean, as Brock knows, my colleague who works closely with Brock at the Capitol, I said, it was humbling to look at the list, right? And then to take my issue forward. But really going back to kind of what the conversation has been about, and Tim setting it up, when a patient fails an antipsychotic, it's not like a patient failing a biologic med because they have psoriasis, right? That patient is now going to intersect with all different levels in our community, and the implications to that patient, the fact that they're not going to regain their baseline, it's different. It's a different issue. And for me, it was trying to just get my issue to the top of 13 pages of proposed cuts and get the organizations be willing to take that issue forward versus whatever else they were seeing that was coming at them.
I think that more than anything is when we're talking to the legislators, they're trying to do the right thing and making sure that we just educate them on doing the right thing for their community. And it can get twisted. I was a prior elected official, so I get how your community comes at you, and making sure that they hear the point of where they're helping instead of hearing the loud noise of, oh, it's just pharmaceutical, trying to make money. Turn it to, hey, there's a lot of different ones, but this is helping your community and saving, so.
And we definitely already touched on this a little bit, but just focus a little bit more closely. So how do coalition members and just advocates in general leverage local narratives and stories to influence legislators? And also, how did relationships, I mean, Wendy, you already touched on this a little bit with texting senators, but how do relationships with individual legislators help move and shape the process?
I was lucky. I served with a lot of them that were in legislation right now as county commissioners. And so I have those personal relationships. And the rural and urban divide is huge in Colorado. So talking between the two, the languages between the two, and, bringing personal stories of what happened in their little tiny towns. Crisis management teams have to go up when somebody's not getting the right medication. And so I think that just talking to them of how this has affected their communities, because not everybody's an urban or metro legislator. There's a lot of them that are small rural areas, and when little Johnny's on the street and having a crisis and nobody can help him, that legislator knows that person. So, talking that way to them has really helped. And quite frankly, I've been lucky to have served with them, so I know their stories behind the scenes because we served for 12 years before. So just talking at a personal level to them has helped.
So I can't speak to the relationship at the legislative level because that's not where I work, but I think, and Brock talked a little bit about this, is that the thing that I would encourage that I think really was effective in Colorado, and listening to the presentations in Amber this morning and the other ones, is there really was a coalition approach, right? You've got industry at the table, we've got contract counsel at the Capitol, I'm going to Mental Health America, I'm going to NAMI, I'm going to the Psych Society, I'm going to Mad Moms, and really just, leveraging the resources across all of those stakeholders to move the process forward, whether that was brainwaves in MHA or NAMI sends out an alert, and what they did was they geographed where the JBC members were and where their advocates were, and then forced out their alerts based on addresses of the JBC members. So whatever it was just really, I would say, it was very much relationship-based, but it was a broad coalition approach, and I think Amber was co-conspirators. I think sometimes industry gets maybe looked at in the negative way of that, but really we were just trying to serve as the convener, right, to bring the group together to move the process forward. And I would encourage you all, as you work in your states, to, I guess sometimes we say in the healthcare environment now, there's a lot of odd bedfellows you start to see now when you start to see two competing hospitals come together, right? Like we see a lot of that happening. I would encourage you to think of someone that may help move the process forward that you wouldn't typically be someone that you would have worked with in the past.
Yeah, I think Wendy and Shannon have hit it very thoroughly, and I appreciated the conversation from Idaho about the baking of cookies. Things like that do not go unnoticed, and if you have that type of relationship, and I am not the best deliverer of a message. I think we can all agree. I'm not a great public speaker. There are some things I should not be doing, but getting to know people, I think, is one of those things that I can do, and when I spend time with them, and that's what we did with these bills, I would go to Christine at J&J, who would talk to Shannon and talk to Mental Health Colorado and say, okay, I need Mental Health Colorado to find a patient to talk to this legislator that is a part-time parent, a part-time worker, a part-time caregiver, a part-time driver for the community, the soccer moms or whatever. This is the type of patient that will respond to that, or this legislator will respond to a person like that. That is something that I think feeds into what I think the advocacy side is so good at, because those personal stories are there. But I think if you just, and it sounds like Idaho kind of had to say, okay, we've got to spend time in the halls, figure out who these people are, and then tailor the message to those people. I think that's exactly what we have to do. And I think with some of that, I was able to do that in real time, give that feedback of, here's where they're getting, and again, Shannon said it so much better than I. They're getting faced with, we have to cut $1 billion. Why should I care about your small sliver of this $400 million? And you have to elevate that. Finding the right type of advocate, not just anybody, I think can go a long ways. And I think that is what helped in Colorado, was giving, especially Amabile and Senators Amabile and Kirkmeyer, the right people that they could say, I don't need any more cover. You've got me. I'm willing to fall on the sword for you. Now get out of my way and let me do it. I think that's when you realize that all functions and all spokes on the wheel are working in the same direction and have accomplished what I think is the right thing for the patient.
Okay. Go ahead.
Add one more thing. When people are looking at your bills, and bipartisan is huge, if you have strong voices from both, and a lot of times they're opposing voices. Amabile is very liberal, Kirkmeyer is very conservative, and they don't see eye to eye. But man, when you can bring them a common cause, they are your biggest advocates to make it happen. And we saw this with this bill. And they sponsored another bill for mental health this last year because of what we established and what prior people established with this act.
Well, that's a great, sets up the last question before we open up to question and answer from all of you. You just mentioned the bipartisanship, and we've heard this through one of the things that's come through today, and I think most people are familiar with. Most state legislatures, Colorado included, and state governments are trifectas, where one party controls the House, the Senate, the governorship. I mean, there's very few states where that isn't the case. So in most states, you can actually pass things by completely ignoring the other party. That is possible, and that happens all the time in state legislatures, but it's actually not the norm. Why is it important to be bipartisan, even in a state when you have a trifecta and technically you don't need to be bipartisan?
I can tell you when I came into Mental Health Colorado, I was from a very conservative area. Didn't always see that they were, and, you know, I didn't think the same way as them, but I was an R. And so I had that lens and that, you know, perspective. When I came in, I looked at our scorecard, and it was 40% for Republicans backing anti-mental health bill. It was 90 to 100% for the Ds. And my first mission was to educate that caucus at the legislation and talk the language with the Republicans of why getting the system to work for everyone was a better way to do it. We are setting at 80 to 90% now for Republicans for our bills. We're very choosy in our bills to make sure that when it is actually getting the system, not making a statement, we're getting the system to work instead of just making a statement to kind of tear down the system. So when we actually support a bill, the legislators look at us and say, this is moving the system to create diversity and equity to everyone. And that's kind of the message we've been carrying. You know, it's not about politics, it's not about a party, it's about people. And so that's one of the things. And we've had a lot of the different people at the legislative call and say, when we see Mental Health Colorado supporting a bill, we know it's going to move, and so we tend to support it and not push back. And so it's been an easier lift once you get that established.
I just go back to the example that was shared earlier about the member who would not vote but influenced the other members, right? So it's the same way that I think of when I'm building my network. We may not align on everything, right? But we come together on those issues we can, or we share information and we pass that along. And I can't imagine at the legislative level, and the example that was shared from Idaho, right, that that's really any different. Just because they're from an R or a D doesn't mean they don't matter based on who's in control at the legislature.
Yeah, I totally agree with what was said, and I think even though I work in politics, it's gotten so bad that it just seems like if you're not one thing, you're the other, and there's no other way to look at it. And to me, I find that on a personal level somewhat gross, because I don't think that that's how we function as humans, and I don't think that that's how we really do think. And when you're talking about somebody's access to a drug that literally changes the way they wake up, the way that they function, what are you doing talking about, like, well, this is a Democrat sponsoring the bill, I can't be on it. Or if a Republican's going to be on that, what am I doing? I guarantee you, if you talk to legislators and say, so you're willing to go back to your district and tell those constituents who I know are calling you, because we've worked with Mental Health Colorado, that I know are calling you, you're going to look them in the eye and say, I'm sorry, I know the bill would have helped you, but a Democrat was on that or a Republican was on that. Are you kidding me? And I think that Wendy is exactly right. Senator Amabile and Senator Kirkmeyer, if you were to look at them on paper and initially meet them, you would say, okay, this one's from way over here and this one's from way over there. And then when they sponsor a bill together, people are like, oh, well, there's something to it, even though I think we should be there anyway. And I think it just lends to the credibility of the issue, even though I don't think it should have to. I think right now, especially in Colorado, you need to show that bipartisan support. And thankfully we did. They're both on the Joint Budget Committee. They're both very well respected within their caucuses in both chambers, and they happen to be respected on both sides of the aisle. It's kind of a no-brainer in that situation, and it did help bring along some of the people that might otherwise be antagonistic just to be antagonistic.
Okay, well, now we'll open up for questions. Anyone in the audience have questions for our panel? Yes?
Well, I'm a person with lived experience, and you talked about prior authorization. And recently, I've been going through a process where my insurance denied one of my medications, and so I got the thing from Walgreens, and they said they had to contact the insurance company. And I got a call. I thought it was a spam, and I ignored it. Turned out to be an AI robot. And so now the AI is making me put through all of this paperwork, and as Amber said, you qualify for it, but it's the paperwork that makes you stop. So I wondered, have any of your lived experience patients or clients came up with that story, or has it reached Colorado, or is it just in Chicago now?
I was going to say we are working very closely with our legislators about AI because AI, it's a nightmare.
It is.
And it needs to be out of our system. There's a time and a place for it, but it basically looking at drugs are, even, taking it down to like a resume. If you don't have a certain word there, it kicks you out. We need to make sure that people look over that and people still have the possibility to evaluate instead of AI. So we're hearing you. We're trying to work with some of the AI stuff. Right now, last year we had a couple of AI bills. We're hoping that this next year that we can get people to take out AI for basically weeding out things and creating more work.
And I would just say your story is the type of example, and I don't want you to think that you're just a story, because it's your experience, you've clearly gone through it. That was the reasoning behind what are we doing trying to balance a budget based on prior authorization and step therapy when the scenarios could be a nightmare even if you do qualify. What happens if you get kicked off of something? And I don't want it to sound like your story is just one of 100, but it was the type of story that you just told that we were talking to legislators about, of this is the scenario you are setting real patients up, and it's sure, I might qualify, but then I fail and fail and fail to try and get what I need to make sure that I'm on the medication I want. And I do think that that has and had an impact where 24-110 was concerned, and then where we were at this past year is I think people are living that same experience with you, and I think that gave our legislators some of the cover to say we're taking the money out of the equation here because of the type of scenario and your experience that you just shared. That's what they're trying to avoid, is unfortunately what you're experiencing.
Okay, yes, and I just want to say that it has been 6 weeks that we have been going back and forth, and so they denied it twice because I haven't sent in what they say is the right stuff. Well, not me, but the doctor. And the doctor just says he doesn't have time, so it's just a whole loop around. So, but thank you for your answers.
Hi, so thank you for a great panel. I'm curious, since we're in a current administration that is not exactly pharmaceutical friendly, from vaccines to SSRIs, all of that, which is not shocking if the person leading healthcare isn't even a healthcare professional. But anyway, I'm curious with that, do you find that mentality trickles down to the Congress level or to even at the state level? Do you find that in your work?
Yes.
Unfortunately.
A lot of our legislators eat and drink that Kool-Aid, and trying to educate them that that's not how it works, that conspiracies don't work. They're nothing but somebody's made up stories. We have to present them with facts, and sometimes they don't want to hear the facts. This administration has been a nightmare on all levels, and I can just tell you, I was a county commissioner during COVID.
Oh, wow.
And dealt with these same mentalities. you just have to keep educating them. It's 2.5 years, 2 years.
I was just going to say, yeah, it does. And to Wendy's point, there are some people in the General Assembly that were like, okay, this administration doesn't like the pharmaceutical industry. I think that why, at a state level even, that presents a problem. That's why it's imperative that we are part of a coalition with Mental Health Colorado, with all of the other advocacy organizations, which is just strange for some, certain sides of the aisle. You have a perception they would love the pharmaceutical industry, and that's kind of been, that dynamic has been shifted or flipped on its head. But that's the beauty of these coalitions, is that it's not just one group or one company or one person that's advocating. It's people like Shannon, Wendy, me giving intel of here's what they need to hear, because I do think you have to take that into account. And it's not just at the federal level. Those views do trickle down to a state, and I would say even a local level.
Thank you for your candor.
Yeah, please.
Hi, Kelly Struthers, State Government Affairs with Otsuka. And I did have the pleasure of working 24-110 and Mental Health America and Johnson & Johnson played very important roles. Mental Health Colorado and Johnson & Johnson played important roles there. Not really a question, but a comment based on, some of my learnings when we were doing 110 and as we've tried to replicate similar bills in other states. Having fierce bill sponsors, Rodriguez, Kirkmeyer, Amabile, to push back on the department, because the first fiscal note that came out on 24-110 was exaggerated. I'm trying to say it nicely. And to have sponsors that go back to the department and say, your assumptions have to be wrong. This, that is their opposition statement, right? That is how they oppose these bills. And we were able to get enough pushback from Kirkmeyer and Rodriguez to get the fiscal note redone. We just ran this similar bill in Arizona, and it had a $144 million fiscal note. They assumed they were going to have a 70% increase in the use of branded antipsychotics. And I'm like, there is no data on earth that supports that. And so I think you have to have, if you go down this path in your state, you have to have willing sponsors that the departments don't want to be told what to do, and you have to have sponsors that will just, go to the mat and fight for the truth when it comes to the fiscal impact.
Kelly, I'll say you'll know this, and so will Shannon and Wendy, if not for the sponsors this past year, because it was the department coming back and saying, we're going to prior auth all of this stuff, to not have, especially those strong Democrats who could not only go back to the department and say, the hell you are doing this, they could go down to the first floor and tell the governor, your departments are out of control, rein it in. So it's a tremendous, tremendous point.
And one of the things that we do is each month we meet with HICPUF, we meet with BHA, we meet with all of these because we want to have that personal relationship. When we push back on them, they actually start talking to us, and we iron out those differences before they go to the legislature.
Okay, time for one more quick question, then we'll wrap up.
Hi, Andrew Smith, Depression and Bipolar Support Alliance. Not really a question so much as a comment. Thank you all for the panel and for the advocacy. We completely agree with the language of fail first with regard to step therapy, and completely agree with the messaging around what does failure look like and how catastrophic can it be with regard to mental health. One thing that I would encourage everyone in the room to consider is flipping the language a little bit and say that the medication failed rather than the person failed on the medication. Thank you.
That's great. Well, please give a round of applause for our panelists. And I will call Alicia back up to the stage.
Thank you so much, folks. I really appreciate your insight, and thank you all so much for your insightful questions. I really appreciate the dialogues we're having here today. So, we have a short presentation, and then we will go to lunch. So I'm going to invite up Hannah Warren from the Bazuki Group to share some research about metabolic health.
I'm really grateful to have the opportunity to be here today to learn more about the wonderful work being done at Mental Health America and to share a bit about the emerging field of metabolic psychiatry. I am an individual with lived experience. I work as the Communications and Advocacy Manager at Metabolic Mind. That is a nonprofit initiative of Bazuki Group, which is a nonprofit private family foundation working to advance the science of metabolic psychiatry. I have set a timer because I'm going to make sure I do not cut into your lunchtime at all. I'm sure everybody's eager to get the opportunity to network. So I'm going to make this short and sweet. I'm going to cover a little bit about my lived experience putting bipolar I disorder into remission using metabolic therapies. I'm going to give a brief overview of the science of metabolic psychiatry. I'm going to speak about more lived experience advocates who are sharing their testimonials, and I'm going to wrap up with sharing some resources that you can explore further. So I was first diagnosed with bipolar I disorder in 2012. I had my first episode of manic psychosis. And for me, it came seemingly out of nowhere at a time when my future appeared bright. I was studying abroad in London at the time with a full scholarship from Rotary International. I was a young social entrepreneur who was seeing success with a nonprofit I had started. It was getting a lot of grants. Everything was going well. One night, I was working on a paper, and I did something I'd done countless times during my undergraduate degree that almost everybody can relate to as a college student. I stayed up all night working on a paper, and usually I would just synthesize my ideas in the morning. Everything would come together. I'd submit the paper just on time before the deadline. But this time, something was different. My thoughts never came together. Instead, they became increasingly erratic. I started to become delusional. I ended up staying in my apartment and not sleeping for I don't know how many nights on end. I began hallucinating. I saw a snake slithering through my apartment. I saw my clothes dancing around on their own. Eventually, I wandered out into the streets and into a nearby church where I asked them to please introduce me to God. Not surprisingly, unfortunately, they did not introduce me to God. Instead, they called the police, who came and took me by force to an inpatient psychiatric facility where I was held down and given antipsychotic medications against my will. I slowly came back to reality. I was there in the hospital for about a month and a half. But as I came back to reality, it was unlike the reality I knew before. It was much darker. I faced severe suicidal ideation that lasted almost a year. I would look at pictures of myself from just months before. I felt like I was mourning the death of myself. I thought, that girl, she didn't know how good she had it. I felt like I had irreparable brain damage, like I was never going to be myself again. Eventually, after about a year, the suicidality finally subsided. But I really faced serious side effects of my antipsychotic medications. I had cardiometabolic side effects, so I put on more than 70 pounds. I felt like I had persistent brain fog and fatigue and impaired cognition. My depth of emotions and my creativity were extremely blunted. While I was able to maintain a job and live independently, My quality of life just never got back to what it was prior to my diagnosis. And so I was desperate to try other solutions, and I had 2 unsuccessful attempts to go off medication where I ended up having a relapse episode of mania and psychosis that required hospitalization. But I was determined to do some research and see if there were any alternatives out there I could try. And so I was scouring the internet, and I found the work of pioneering metabolic psychiatrist, Dr. Christopher Palmer, who is based at Harvard. And I learned about this new modality that I wanted to try called ketogenic therapy, following a ketogenic diet as a treatment for a psychiatric condition. I'm a vegetarian, so I did a vegetarian approach to ketogenic therapy. Long story short, it has been more than 5 years of me using solely ketogenic therapy as my form of treatment, and I have had no episodes of depression or mania. And I want to be really clear that many patients come to this form of treatment with different goals. Some, like me, are really eager to reduce or even eliminate psychiatric medications, as I have done, due to debilitating side effects. Others are looking to explore ketogenic therapy as adjunctive to their current treatments. And in both cases, we're seeing remarkable success stories. People who are able to reduce medications that have troublesome side effects or go off of them entirely, as well as people who say that this form of treatment alongside their medications without changing anything else has transformed their quality of life. And all these forms of success story are equally valid. I do want to say that it's very critical if anyone's doing ketogenic therapy. It is a powerful medical intervention, and they need to work with their clinical care team, especially if any medications are being adjusted. Any type of tapering or reduction of medication needs to be done very slowly with the help of clinician. And of course, this is emerging science, so we cannot, of course, guarantee the same results for everyone. But we're seeing enough in these testimonials to really believe that this is an intervention worth trying. So I'm now going to share a short video from our medical director, Dr. Brett Scher, which gives an overview of the science and research to date on metabolic psychiatry. Just gonna give it 1 minute because it's really nice to hear him talk about it, and there's some animations that make it feel more digestible. But if we have an issue with it starting, I can give the brief kind of overview myself. So I'll go ahead and do my little spiel. And to give you the disclaimer, of course, I'm a person with lived experience. I'm not a medical professional. But when we're looking at ketogenic therapy, what a lot of people don't realize is that a ketogenic diet has been used in treatment-resistant epilepsy for more than 100 years. So it's really seen as a powerful neurological intervention, enough to stop treatment-resistant seizures. So it changes your brain chemistry. What we also realize is that it has a powerful impact on mitochondrial health, which is your body's ability to transform and utilize energy. When you're in a state of ketosis, your body switches fuel sources from burning glucose to burning ketones for fuel. We know that some people seem to experience insulin resistance in the brain, meaning that their brains are not as well able to utilize glucose for fuel. In that case, ketones actually have a shortened pathway, so they're able to utilize that energy more efficiently. The ketogenic therapy as an intervention has this long history of being used in epilepsy and used for other metabolic syndromes, conditions like obesity, type 2 diabetes, and it has been shown to be effective in that. But now there's over 40 studies actually looking at ketogenic therapy for neurological and psychiatric conditions. At the end, I'm going to share our research database with you. So there's actually already been 4 pilot trials and 2 randomized controlled trials looking at ketogenic therapy for psychiatric conditions and showing really promising results. There's also more than a dozen trials that are currently underway. We keep our research database really up to date so that you can see these results as they come out. And to basically explain, one really important thing is keto is not one diet. There's many misconceptions. A lot of people think of it as this fad diet that is very heavy in meat. And I'm a great example that it does not need to be that way. I've been following this vegetarian ketogenic diet for more than 5 years. I've also interviewed people who have success stories who've been doing ketogenic therapy as a vegan, completely plant-based. And of course, there's also the other end of the spectrum, people who eat very meat-heavy diets. But really, it's an extremely versatile way of eating that can be tailored to your specific needs, your specific dietary needs, as long as you reduce carbohydrates enough to switch the body's fuel source from glucose to ketones, you can successfully do ketogenic therapy. One of my favorite things about working at Metabolic Mind is getting to interview other people who have remarkable success stories. As I mentioned, some doing ketogenic therapy adjunctively, some who've used it like I have as an alternative. We now have dozens of testimonials on our website, and it's really transdiagnostic. I've interviewed people who have overcome symptoms of bipolar disorder, schizophrenia, OCD, PTSD, depression, eating disorders, and more. Sometimes I even speak to people who experience really treatment-resistant psychiatric conditions, who were completely disabled for years or sometimes decades and have actually had their lives restored through ketogenic therapy. One example of that is Matthew Bazuki, whose story is also featured in our database. He struggled for about 5 years, and his family had the resources for him to get the best possible treatments. He was put on cocktails of over 29 different medications, saw countless specialists, but nothing was really restoring him. Ketogenic therapy brought him back to himself. Within 4 months of doing keto, his symptoms were in remission. He is now living independently, working full-time, and he has fully restored his executive function. I've had the opportunity to interview a number of people who have this type of incredible story. There's another short video I was going to play. I'm not sure if that will work or not, but this is a way to give a taste of some of these powerful stories. They're designed not only to inspire hope, but also the individuals share very practical strategies of what worked for them in terms of their particular approach to the ketogenic diet, but also the way they approached metabolic therapies at large. Metabolic therapy is really an umbrella term, and it encompasses anything that helps improve your body's ability to transform and utilize energy. While we talk about ketogenic therapy as a very powerful cornerstone intervention, it is not a silver bullet. There's other things that people are doing in terms of sleep hygiene, managing stress, staying away from harmful substances, making sure that they regulate stress, that are helping these people to maintain their long-term stability. So here's a quick video to give you a taste of some of these incredible stories.
Anyone thinking about starting a ketogenic diet or even wondering, could this actually work? Give it a chance.
It has had a profound impact on my experience of my illness. Now I'm more driven, I'm doing better, I'm more motivated to do things. I participate in life.
Feeling better than I've felt in an extremely long time.
Once I started to implement the diet,
was when things really shifted for me.
The intrusive thoughts that I had really struggled with my whole life were just gone.
It really did have the effect of like a really, really positive medication adjustment without any side effects or without having to take medication.
I think I'm like a fully functioning person now.
It absolutely changed my life. There's a night and day difference.
If you have worked with a good psychiatrist and you have tried multiple medications, different classes of medication, and you aren't in remission from your illness, then like, what do you have to lose?
So as I mentioned, this is our research database where you can look at all the trials that have already been published, and it will also keep it updated regularly with new trials as they are published. And I got the good news that we can now play the short video, and I'm going to wrap up, and we'll leave it with the words of Dr. Brett Scher. He can explain it much more eloquently than I did, so I'm really glad we'll be able to share that video. Thank you so much for allowing me to share my story and a little bit about metabolic psychiatry with you today.
Another weight loss diet. It's a powerful medical intervention with medication-like effects on the brain and body. In fact, it's not just one specific diet at all, but a therapeutic process that reduces carbohydrate intake to shift the body's primary fuel source from glucose, derived mainly from carbs, to ketones produced from fat. This metabolic shift can be achieved through a wide range of dietary approaches, from vegan to carnivore and everything in between, as long as the carbohydrate intake is low enough. Now, medical use of a ketogenic diet began over a century ago to treat drug-resistant seizures. Now, ketogenic therapy is showing promise for other neurological and psychiatric disorders. Ketogenic therapy has been widely studied in hundreds of clinical trials to assess its effectiveness in treating metabolic conditions like type 2 diabetes or obesity and polycystic ovary syndrome. That same metabolic approach is now being extended to brain health in psychiatric and neurological conditions with a wide range such as bipolar disorder, depression, schizophrenia, anxiety, OCD, ADHD, PTSD, eating disorders, dementia, Parkinson's disease, and even ALS. Across the globe, individual patients, clinicians, and research teams are reporting meaningful clinical improvements and often life-changing recoveries. Over 40 clinical trials have been completed or are currently underway, specifically focused on serious mental illness and neurological disorders, and that number only continues to grow. While research continues to uncover exactly why ketogenic therapy works so well for many psychiatric and neurologic conditions, key mechanisms are already coming into focus, including stabilizing brain energy, reducing neuroinflammation, boosting mitochondrial function, and modulating neurotransmitters. Ketones provide a more efficient and accessible fuel source for the brain, especially for individuals with insulin resistance who may struggle to effectively use glucose. You can think of insulin as the key to unlock the cell's door, to open it and take in glucose that the body uses for energy. But when you have insulin resistance, it's as if someone changed the locks, and the insulin doesn't work as well in opening the doors. The result is a cell that's essentially starved for energy. But ketones don't need the door or the lock. They can come in through the open window, thus providing an efficient energy source even when someone has insulin resistance. Ketosis also strengthens both the quality and quantity of mitochondria. From transforming food and oxygen into energy to fine-tuning hormones and neurotransmitters, and even guiding gene expression, these tiny organelles play a central role in our health. When mitochondrial health is restored, the brain and body can gain a vastly improved energy flow, which opens the door to lasting stability and wellness. As research evolves, one thing is clear: ketogenic therapy is worth exploring for brain health and mental well-being. It's a relatively low-risk intervention with the potential for profound, life-changing results. With the right clinical support, it can offer hope and real healing for people who've been told recovery isn't possible. If you'd like to learn more, please visit us at metabolicmind.org.
Hannah, thank you so much for bringing this really interesting topic to this meeting. We are now going to break for lunch, What I'd like you to make sure you pay attention to is that we do have some Cato offerings for our lunch today. So please enjoy the wide variety of delicious food. If you have questions for Hannah, please connect with her at lunch. And again, I'm hoping that this presentation will give you some food for thought to discuss with each other as you network. Please enjoy our lunch. Excuse me, folks. If anyone is lost because I didn't give good instructions, our lunch is out this door to the left in room B. Thank you. Chris, can you hear? How's the other? All right, folks, we are going to swing into the last half of our meeting. So please settle in your spaces. Make sure you get a cup of hot tea. Keep those hands warm. Thank you all so much. Appreciate you coming back. Thank you. So, it's on the top of all of our minds. Our next presentation is about Medicaid. With cuts on the horizon, it's even more important to partner with Medicaid directors as advocates. I'm pleased to have Lindsay Browning, Deputy Executive Director of Programs from the National Association of Medicaid Directors, joining us virtually to offer ways to cut through the noise and connect with state Medicaid directors. Take it away, Lindsay.
Wonderful. Well, thank you so much and deeply appreciate the opportunity to be here with you all. I am sorry that I can't be there in person, but thrilled to be able to join you virtually today. I want to tee up the conversation with a little bit about NAMD and the perspective I'm offering today, and then hopefully leave you all with some tips and advice for effectively engaging your Medicaid program. So let me pull up my slides here. So for those who don't know, the National Association of Medicaid Directors is a professional nonprofit association supporting state and territorial Medicaid leaders across all 56 states and territories. We support Medicaid leaders through thought leadership on operations of Medicaid programs, by amplifying the diverse perspectives of the state and territory Medicaid leaders, and really optimizing that federal-state partnership that's so critical to the program. We are not an advocacy organization and by and large do not have perspectives on an array of policy matters, but really focus on supporting states through connection, convening, and operational insight across the states and territories. So for those who aren't as familiar, the Medicaid director role is really a unique job. I've been working with Medicaid leaders at NAMD for almost 12 years, so I've had kind of a front row seat to this unique role that they play. And really their role in leading the program is to kind of set the strategic direction for their Medicaid program within the context of state and federal directives, rules, et cetera, and to really partner as an executive branch staff member, leader with the legislative branch, with the governor's office in setting that strategic direction. They lead their agency in administering Medicaid, so ensuring the program is functioning, benefits are being delivered, folks are being determined, eligibility determinations are happening, et cetera. So really kind of leading the day-to-day functioning of the agency of the program. They're responsible for ensuring compliance with both state and federal law. And I think this is really important to keep in mind, that leading a Medicaid program really involves this complex array of regulatory and statutory layers, both at the state and federal level. And Medicaid leaders have to navigate within that and ensure compliance to a wide array of requirements. And then finally, Medicaid directors are really accountable to lawmakers, both at the state and federal level, for program performance, and to the public. Medicaid is a publicly funded program, and so that accountability to the taxpayer for the effectiveness and impact of the program. So with that level setting in mind, I really want to offer 3 tips today for partnering with your Medicaid program in your state. The rest of what I'm going to share is kind of organized around these 3 tips. The first is encouraging you all to understand the current context for your Medicaid program. Each state and territory is unique, so understanding your state's context is really critical for effectively approaching and partnering with Medicaid. Second is to find opportunities to be a resource and to offer yourself as a resource for your Medicaid agency. And third is to build relationships at multiple levels. So yes, the Medicaid director is an important position, but I'm going to talk about how you might broaden that a little bit as you think about building that relationship. So that's the game plan. So let's start with tip number 1. Understand the current context for your Medicaid program. This is so critical when you approach Medicaid and maybe have a set of asks or things you want to raise. If you understand the context and the pressures and priorities facing your state Medicaid program, you will be able to frame that conversation in a way where you have a receptive audience, where the folks on the other side of the table also feel seen and heard. So I'm going to share some insights on what the current context may look like for your Medicaid agency in the current moment, to help situate you for having conversations for engaging with Medicaid. So generally, there are 3 kind of key areas of current focus for Medicaid programs, by and large. Again, this is going to differ a little from state to state, but these 3 realities are really important to keep in mind as you're approaching your Medicaid agency. The first are state and territory budget realities, including some of the layering effects of policy changes that are going into effect, implementation of H.R. 1, or the One Big Beautiful Bill Act, also known as the Working Families Tax Cut legislation. And then third is the federal initiative priority effort to address healthcare fraud, waste, and abuse in Medicaid. These are 3 really influential initiatives or efforts that are top of mind for Medicaid right now. And again, my goal here is to equip you with some insight to understand the context facing Medicaid for when you approach them for conversations. So let's start with budget pressures. So I probably don't need to tell you all this, but for many states, most states, the budget outlook is tightening. We are entering a period of belt tightening, of states facing more challenging circumstances to balance their budgets. Part of that's due to slowing revenues, part of that's due to ongoing healthcare cost growth, but it's confronting most states as we look at budget development for next year. We know that Medicaid costs account for about 30% of total state expenditures in the budget and almost 25% of state general fund expenditures. So necessarily, whenever a state is facing a tough budget environment, Medicaid has to be and is necessarily a part of that conversation for governor's offices, legislatures, et cetera. We also know that this past cycle, many term limited governors deferred budget cuts to next year, which means this challenge of constrained budgets will coincide with many incoming governors who are eager to advance their policy agenda, which is going to create a tough set of circumstances, but also potentially some opportunity for positive disruption and change. The third thing, or the final thing I would say here, is that federal policy changes to provider taxes, state-directed payments, and even some of the changes to 1115 waiver budget neutrality are going to start taking effect over the next couple of years. And these are expected to increase budget pressures for many states, depending on how they use those mechanisms and whether the state is an Medicaid expansion state or a non-expansion state. So the bottom line for you all here is when you're approaching Medicaid in this current environment, really be sensitive to the fiscal context for Medicaid. For example, if you approach them asking for, expansion of services or higher payment or those sorts of things, those may not fall, they may fall on deaf ears given just the current realities. But instead, I think approach from a place of helping to identify opportunities for savings, looking at those places where affirmative disruption could be advanced in a period of budget pressure, et cetera. The second key area of focus for many Medicaid programs right now is implementing the One Big Beautiful Bill Act. As you all know, the law establishes new conditions on Medicaid eligibility, particularly for what's known as Medicaid expansion adults. These are the childless adults that many states opted to cover under the Affordable Care Act, the Medicaid expansion. And a number of those are listed here, working community engagement requirements that have gotten a lot of attention, but a number of other eligibility changes that have been a little bit less front and center in the policy discussion, national discussion, like changes in retroactive coverage periods in Medicaid, for example. So what I would say here, the bottom line, and I'm going to go into working community engagement requirements in a little more detail, but as you engage your Medicaid agency, it's important to know if some of these OBA policies affect your state or not. I will say earlier in the year, a lot of non-expansion states were hearing from advocates around working community engagement. And I think that can be, that's not necessarily helpful to be approaching them about something that may not apply in their program. So know whether or not your state is an expansion state and whether or not some of these requirements actually apply to them before approaching them for a conversation. So let's talk a little bit deeper about working community engagement requirements. I suspect that's where a lot of attention is or has been in your all's conversations so far at the meeting. We know that the implementation date is January 1, 2027 for all states. Some states have elected to go early. But what I really want to call out from this slide is that states must begin noticing individuals about the requirements starting in end of September. So this is really a period of time. We've seen the interim final rule come out from CMS. States are really baking in kind of policy decisions, working on the IT systems changes. They're really turning their attention to the noticing and how do we reach members with key information about this. And I'll get to this in a little bit, but I think this is a crucial time and opportunity for you all and your partners in the community to be linking arms with Medicaid to help get the word out. So you all probably know this, but just to reiterate, the working community engagement requirements, again, apply to Medicaid expansion adults or states that have an expansion-like program through an 1115 waiver. To meet the requirement, an individual has to be working 80 hours per month, completing 80 hours of community service per month, participating in a work program, or enrolled in an education program at least half-time, or some combination of the above. So that 80 hours of some combination of those things is really the benchmark. There's also other pathways to meet it, like having monthly income that is more than the federal minimum wage multiplied by 80 hours, and then an approach for seasonal workers. But I think of most relevant for this group, and where there's been a lot of national conversation, is around the populations that are exempt from these requirements, and how those exemptions will be implemented. Much like you all, Medicaid leaders are really focused on this, particularly the medical frailty exemption that was further articulated in the interim final rule. So the regulation that came out from CMS articulates that there's this two-part approach for individuals who are deemed kind of medically frail and exempt from work requirement. First, that person has to be blind or disabled, have a substance use disorder, disabling mental disorder, or a physical IDD that significantly impairs ability to perform one or more activities of daily living, or another serious or complex medical condition. And then the second part of the approach is that condition has to significantly impair the individual's ability to comply with the community engagement requirement. So the ability to volunteer or participate in education or work, et cetera. The expectation outlined in the federal guidance is that states have to use lists of diseases or diagnoses, et cetera, to help define those categories. But I want to call special attention to this last piece, that those lists have to be auditable, justifiable, and consistent. And states are very eager to make sure the approach that they come up with really does meet those tests, and the state won't be out of compliance when audits come, year or 2, 3 years down the road. So the way that I've heard Medicaid leaders thinking about this approach to medical frailty is really sort of two principles. The first is automate wherever possible, right? To really layer on, diagnoses codes and other frameworks with other data that can sort of automatically capture folks who may meet the medical frailty criteria. But there's also a recognition that there's going to have to be manual processes to wrap around the individual. And I think this is where there's been a lot of conversation and discussion of, what does that look like? Is there a clinician assessment of ability to work? Will providers be able and willing to play that role, et cetera? So lots of ongoing conversation among states and with states and CMS around those matters. I also want to point out a couple of other notable areas of focus around work and community engagement. Self-attestation, meaning if I, Lindsay Browning, were applying for Medicaid, I could sort of self-declare that I meet certain exemptions or certain criteria. In 2027, there's a more permissive use of self-attestation. In 2028 and beyond, there is a higher expectation, a requirement that states use reasonably available documentation before accepting self-attestation. And then that self-attestation is only available once to an individual per period of enrollment. So the bottom line, what this means is there's going to be, yes, this push around implementation of work and community engagement for January 1, 2027, but the work is going to continue. So as you think about partnering with your Medicaid program, don't see 2027, January 1 as the finish line, but there's going to be a lot of opportunity to look at other sources of data, to further automate, and to get ready for some of the changes that come in 2028 as required under the rule. Finally, on community engagement, I want to talk about this overlay with audits. And for those who don't know, PERM is the Payment Error Rate Measurement program that is a federal audit program. And this is top of mind for Medicaid directors as they implement community engagement for a couple of reasons. First, the law, OBBBA, essentially limits CMS's ability to grant good faith waiver for PERM errors that exceed 3%. So what this means is that Medicaid programs starting in 2029 will face financial penalties when perm error rates exceed 3%. A nice way to think about this is it's similar to what's happening on the SNAP side, where higher error rates in SNAP, Supplemental Nutrition Assistance Program, result in states having to contribute more money to the program. So similarly, we're going to see this type of policy in the Medicaid space. Now, why this is important is whenever there's new eligibility policy implemented, perm error rates necessarily increase because there's this period of ensuring kind of fidelity to the new rules. Why this is important for you all is to understand as you approach Medicaid, accuracy of eligibility determinations and keeping error rates low is going to be top of mind. Because they recognize this fiscal exposure that's coming starting in 2029. So if you hear your Medicaid program or your Medicaid partners talk about the need to really get that accuracy right, or to be doubly, triply sure that their medical frailty approach is consistent with federal policy, that's really where some of that is coming from. And then finally, in this context piece, I want to talk briefly about program integrity. And I'll keep this brief because I want to get to some questions from you all and discussion. But you all have probably seen, CMS is advancing a program-wide focus on fraud, waste, and abuse. And there's been a big focus on certain high-risk services. And I will note that some behavioral health services have been an area of focus there. There's also an interest on the eligibility side, particularly around appropriate determination of immigration status. But really where we've seen a lot of focus most recently is on those high-risk services. Now, Medicaid programs have a strong interest in addressing fraud, waste, and abuse, and are working with the federal government to collaborate on some of the initiatives mentioned on the right here that the federal government's advancing. But this is important for you all to understand because program integrity is going to be top of mind for your Medicaid partners as you engage with them, particularly in some of these high-risk services. Some of the strategies that states and territories are advancing to address high-risk services include kind of looking upstream at how benefits have been designed, how policies are designed to really prevent opportunities for bad actors to come into the program. They're also looking at kind of criteria around which providers can diagnose, refer, and treat, requiring additional certification for providers, et cetera. And then also, as I mentioned, some of those proactive strategies like leveraging enhanced data analytics, strengthening their relationship across state government to be able to address bad actors, and increasing the use of technology to really prevent fraud, waste, and abuse. The bottom line here for you all is that partnering with Medicaid on these efforts is really critical to addressing the bad actors that exist in the system and preserving access for the people who need it and to the good actors, right? I think we've seen sort of this pendulum in situations where, significant fraud has been uncovered, where there may be an effort to swing really far the other direction to tighten up policies. And so proactive effort to spot concerns, program integrity concerns, and really address them early is critical, I think, to preventing potential harm to access for the people who need the services and to the good actors, the good providers delivering these services. The last two tips are really quick. First, be a resource. We talked about understanding the context for your Medicaid program. As you approach your Medicaid agency, there are some really concrete things you can do to say, hey, I'm here to be a resource for you. I'm not just here asking for X, Y, and Z thing. So a couple of those ways that you can be a resource. First, serving as a trusted messenger, particularly for spreading the word about the OBBBA policy changes like working community engagement requirements. Medicaid programs need you to help them reach the people with messages that are clear and concise about what's changing and what's not. The second is to be an advocate, to be a cheerleader for Medicaid agencies to be well-resourced, particularly when it comes to eligibility staff and for the technology to help automate and smooth the processes for people served by Medicaid. Third, providing data and information about what communities need. You guys are on the front lines, and you can help Medicaid programs spot those opportunities to improve outcomes and maybe address some of the state budget realities along the way by getting efficiencies by aligning resources. And then finally, offering your expertise on mental health and well-being, including where you see opportunities or where you're hearing opportunities in the community to protect program integrity and make sure folks are getting high quality services from legitimate, qualified providers. My tip number 3 is to foster relationships at multiple levels. It may be easy to sort of focus on the Medicaid director as being the primary one you want to connect with, but there is significant value in kind of building relationships with deputies, with folks who are leading bureaus within your Medicaid agency. For a number of reasons. First and foremost, there really is a high incidence of leadership transitions in Medicaid. I have here a couple of stats around, current realities that most Medicaid directors are in their first 2 years of service. And this incidence of transitions is likely to increase given gubernatorial elections in November. I think there's 38 states and jurisdictions that have elections, and in at least 21 of those, the incumbent governor isn't running or can't run. So we will see significant Medicaid director turnover. Those deputies, those folks at additional layers down within the agency really are the glue or the connective tissue during transitions. So building those relationships as well as building relationships with the Medicaid directors really will help you maintain that close connection throughout periods of transition. So just to recap, here are my 3 tips. I hope this situates you well to engage and partner effectively with your Medicaid program. But first is just understand the current context for your Medicaid program, particularly current realities around budget pressures, implementation of federal policy, and program integrity. The second, be a resource. You all have immense expertise and there's really an opportunity for a mutual relationship and supporting Medicaid with their priorities. And then third is to really foster those relationships with your Medicaid agency at multiple levels. See those opportunities to engage with staff a couple of layers down within the agency as really a critical opportunity and critical connection point. So I will stop there. I know we started a little late and now we're a little behind, but if there's time, I would love to take any questions.
Lindsay, we're doing just fine on time. I'm going to circulate for questions.
Wonderful.
I don't see any questions, but I'm curious about my audience, if you don't mind. How many of you have already interfaced with Medicaid directors as advocates? Okay, I'm seeing about a third. Thank you very much. Okay.
That's fantastic.
Right. And then how many of you are from states that's going to be getting a new governor? Ooh, a third again, maybe a little more. I think you see an opportunity here, right? Any questions? Great. Well, thank you so much. I really appreciate you being able to be here today with us virtually. Thank you so much, and I'm looking forward to connecting later in the future.
Thank you so much. Really appreciate the opportunity, and thank you all for your leadership in your states and communities. Just really deeply appreciate it.
Thank you.
Okay.
Okay, thank you, folks. I know Medicaid is really on your mind and thinking about how we can have a little bit more agency around advocating. I hope that her presentation gave you some tips. So, returning to the good work being done in our host city, I'd like to bring Mark Hireman back to the stage. If you don't know, Mark is the Public Policy Committee Chair at Mental Health America of Illinois, And today he is joined by Mental Health America's own Maddie Reinhardt, who's the Senior Director of Population Health. And they're going to discuss how to use local data as an advocacy tool. And as you may see, Maddie is going to be joining us virtually.
So Maddie, why don't you just go ahead?
Perfect. Can you all see my slides and everything?
Yep.
Okay, amazing. Well, thank you so much for that introduction, Elisa, and thank you for having me today. I'm sorry I can't be in person with you all, but I am excited to talk to you about using real-time data for advocacy in Cook County. So again, I'm Maddie Reiner. I'm AHA's Senior Director of Population Health. I know at this point in the day, actually, you all are very familiar with MHA's national office, so I won't take your time with any background into our organization. But in case you are not familiar with our National Prevention and Screening Program, it is a collection of over a dozen free, anonymous, confidential, and validated screening tools that allow people to explore their health online. So these are screening tools that would be used in the provider's office to screen someone for a mental health condition, but we put them online where we found that people often search for answers when they are first experiencing. Since 2017, over 30 million screens have been completed, making this the largest real-time data set ever collected from a help-seeking population for mental health conditions. So when someone comes onto our screening website and takes a screen, well, first they can decide which screen to take. Here you can see in these teal bubbles on my screen, those are the mental health screens that we have available to them. So they range from tests for depression and anxiety to bipolar disorder and psychosis, all the way now to OCD and gambling addiction. So once someone submits a screen, they're given their results, an explanation of how their screen is scored and what that result means for them, and articles, worksheets, and interactive tools that can provide more information about mental health and begin to introduce coping skills for them. And then on our end, we're able to receive the de-identified data from both the screening tool itself as well as optional demographic questions. So those demographics, which you can see on the right, upper right corner of this slide, they include standard demographics like age, gender, race, ethnicity, to questions about whether someone has ever received treatment or support for their mental health before, or if they're currently receiving treatment and support, all the way to really in-depth information, like whether they identify as a special population, like LGBT+, students, veterans or active duty military. And we also ask questions like, what are the main things contributing to your mental health problems at the time that you're coming on and taking the screen? The demographics also include zip code and state information, which is how we've been able to drill down to the zip code level within Cook County, which I'll show you in a moment, to really drive that for local policy and advocacy work. So overall, all of this data just helps us to understand people who are struggling with their mental health and follow what they're telling us to guide decision making. So our overall goal is to use screening data to rapidly analyze and disseminate this information to help fill unmet needs and gaps in care for our communities. So we have used it to inform new policy decisions, the creation of new programs, to better direct resource allocation, and to tell us where there may be programs or policies that are working that can be scaled to other spaces or other communities where people are not currently being served. There are a few things that sets this data set apart that really makes it unique, that are important to keep in mind for that decision making. So one is that it's largely reflective of emerging unmet mental health needs. And what that means is that the individuals who take a screen through this program often have very high symptom severity and no previous experience with mental health supports. So, for example, in 2025, 79% of all individuals who took a mental health screen in the US scored with moderate to severe symptoms of a mental health condition. And of those individuals, 56% had never received any prior supports for their mental health. And so what makes this data set really useful is that it can be used as a tool for earlier intervention. Again, we find that when people are first experiencing those symptoms of a mental health condition, they look for information on the internet the same way people do for physical health conditions before taking them into a provider. And so this is really important because most mental health data that we have access to is collected once someone has presented in the health system, either through claims data or really once someone has a diagnosis. And this data set is capturing that information often much earlier, well before someone would be telling someone in their life about what they're experiencing. Our screening population is also skewed very young. So in 2025, 44% of screeners were youth under 18. So again, this data set is showing us more upstream imminent need for mental health support in these communities so we can make changes to support people as early as possible. And we've also found through our research that people are more likely to turn to MHA screening when they don't know where to go or how to start receiving mental health care, or if they live in mental health deserts where services that are not available to them. So that can show us where we can fill those really unmet needs and gaps in care in communities. And we've also been able to collect and analyze this data in real time without the 2 or 3 year delay that we often face with really large scale population level mental health data sets, which allows decision makers to be more responsive to ongoing or emerging mental health needs while they're. So how can you actually use this data to inform the work in your community? We started this work by mapping the MHA screening data at the state and county levels across the US and publishing it online so that people had access to it. And through that work, we started to see that there really was a huge appetite for taking this data to inform decision making. So we heard from several communities across the country about a real lack of available and timely mental health data, especially for youth, and how this data was really important to them. So we had outreach from health departments, for example, integrating the data into community needs assessment to be able to make funding decisions and inform youth programming. We also heard from several of our MHA affiliates in Illinois, but also in other states like Minnesota and Tennessee, that they were able to take this data to their state and local policymakers to show them how to allocate funding more effectively and improve mental health service delivery in areas that we could see in the data had really heightened mental health needs and a lack of available services. And through this link and QR code, you can access that county and state dashboard. Then building on that work, we wanted to turn our focus to a more local approach where we could drill even further down to the zip code level within a single county and start to share this data with stakeholders on the ground to try to come up with even more specific policy recommendations and guidance based on the data. And we chose to focus on Cook County as our pilot because when we did the initial national data mapping work, Cook County was among the top 20 counties with the highest rates of several mental health conditions, including severe depression, PTSD, and suicidal ideation. So in 2022, MHA began working with Mental Health America Illinois to lay out a framework for building that local dashboard and developing an actionable pathway to support policy and programming opportunities for the county. And this work culminated in a report with findings from the data and recommendations for policy changes based on those findings. And then also a public data dashboard, which you can see a screenshot of here, but is also available both on MHA Illinois' website and MHA National's website. And that dashboard is now being updated to have data through 2025. So this dashboard provides a visual representation of rates of depression, anxiety, PTSD, psychosis, suicidal ideation, which we get from looking at people who took a depression screen and reported experiencing thoughts of suicide or self-harm more than half the days or nearly every day of the previous 2 weeks, and trauma, which we get from people self-identifying as trauma survivors in the demographic questions. So each of the maps in the dashboard rank zip codes based on the number of people scoring at risk for each condition divided by the population residing within the zip code to get a positive rate per 100,000 people. So we could standardize across zip codes. So in the map here, we're looking at depression rates. And here the light blue is showing zip codes with the lowest number of people scoring at risk for depression per 100,000. And the dark blue is showing the highest depression rate per 100,000 people. Having data like this allows you to start to see patterns of need. So here for depression, we saw that 12 of the top 20 zip codes with the highest rate of people scoring at risk for depression were in Chicago. And overall, and among youth under 18, when we looked at the data by age, the zip code 60603 in Chicago had the highest number of individuals scoring at risk for depression per 100,000 people. So there is a higher proportional need for mental health resources and supports in that zip code. But in addition to looking at individual zip codes, the map really allows us to identify clusters, and that is what has stuck out as important to us. So the clusters of high-risk codes can tell us, again, where those additional resources may be needed, or even from a population standpoint, where there could be something structural or in the community level, or even in the physical environment that is affecting mental health. So when we looked at depression, we see an area in high need. You can see in that dark blue around the Loop and northern Chicago. We started to see a cluster around Elk Grove Village, and another really notable cluster around Evanston. So each of these areas are places that we identified as warranting additional attention when deciding where to distribute mental health resources. So when we were initially doing this work, in 2022, one of the primary use cases after this data was in planning and implementation of crisis services around 988, because we were thinking about that rollout. So with mapping our suicidal ideation data in particular by zip code, we could see where there was an imminent need for more suicide prevention resources or resources along the continuum of intervention as part of 988, like mobile teams. Another capability we have with this data that we collect is that once we've identified these clusters, we can dig into that additional demographic information that we have access to understand even more about mental health needs. So first we can see where there is high risk within a zip code or a county, and then we can see what people are saying they're struggling with most in those zip codes. So in our demographic questions, one of the questions that we ask is, what are the main things contributing to your mental health problems right now? And people can choose from a list of options we provide or write their own responses. So of those who collected from the options we provided, we can see that in that higher risk area we identified around the Loop in Chicago, youth were more likely than the national and state averages to report struggling with relationship problems, school or work problems, loneliness and isolation, grief, and financial problems. So knowing this additional information, we can start to look at the communities and ask, what does school-based mental health look like in this community? Or are there specific supports for that 12% of youth scoring at risk for a mental health condition who are reporting that grief is driving their mental health concerns? Or is there a way that we can increase connectedness and reduce loneliness and isolation for young people in these zip codes? Elk Grove Village was also a neighborhood that we saw consistently showing high risk for depression, anxiety, and suicidal ideation, especially among youth. So when we asked peers from Elk Grove Village the same question about the things that were contributing most to their mental health problems, over half reported experiencing loneliness or isolation. And so they took their free response field where people had written in and told us what they were experiencing and generated a word cloud. And we can see from these write-in responses that youth were really citing issues with school, extracurriculars, work, burnout, and family issues. So these findings started to highlight the need for us to think through resources to support full families, and understand the challenges faced by children as they're navigating school, work, and social responsibilities, and then explore opportunities to invest in mental health promotion in these spaces where youth are telling us that they're struggling. And this data can also show us where things are not working. So thinking about the theme here today, you can also use the data to see where maybe divesting an area or a program causes spikes in mental health needs, or where resources need to be allocated differently. For example, if we're looking for responses from youth who are struggling with mental health and they're telling us they're struggling with academic pressure when we've been focusing on something else the whole time. These are just examples, but it's showing how the data can be another tool in your tool belt to listen to lived experience at the population level and guide that decision making, especially as resources become really tight and you need to be strategic about where you're placing them in communities. I'm sorry, this table is so small. But one of the newer optional questions that we asked that we started asking in 2026 is modeled after the treatment barriers questions asked by SAMHSA in the National Survey on Drug Use and Health. So we've started to ask, we've always asked screeners whether they've ever received mental health treatment support before. And now we've started to ask if they report that they haven't, why not? What has prevented you from seeking treatment in the past? So in Cook County, we can see that most people report that they haven't received care because they wanted to handle their mental health on their own. That's consistent with SAMHSA's data that they track across the U.S. That's always the reported reason. But then you can see that that was followed by 36% of people saying they didn't know how or where to start finding support for their mental health. And then another 25% of youth saying my parent or guardian wouldn't let me, or I didn't want to ask them for help. And so kind of demographic information can be really valuable for us to bring to community leaders and policymakers to show there's a clear need for more mental health education, for resources to help people navigate and understand the mental health system and where they're supposed to start if they are experiencing challenges, and maybe even more family education or school-based mental health support so that youth and families can be more comfortable discussing mental health challenges and seeking help. So all of this information can just help us make more informed decisions about what is needed in our communities. And so with that, I have a very quick plug that affiliates and partners can have access to this data. We have partnership options to share our demographic information and even match screening data with you if you want more granular data than we have publicly available through those dashboards. And we are going to be piloting a new program to bring online screening into more schools, youth serving programs, and clinic settings. So if that is of interest to you, I will put my contact information somewhere so that it can be shared with you in the slides. And we can connect offline. But before we conclude, I do want to turn it over to Mark Ireman from MHA Illinois to talk about how this data has been useful for policy and advocacy work.
Thanks so much, Maddie. So just to be clear, Maddie did all the work, and then she gave it all to me, and with some ideas about what we should do with all this data. So we've presented this data in a variety of fora here in Illinois, including to joint sessions of legislative committees, et cetera. But let's just, I would like to emphasize a couple of things from Maddie's presentation and how they connect to how we can use this material. So, as you heard from Maddie, the people who come to the website are overwhelmingly people who have problems. Otherwise, they probably wouldn't be looking for a website that is going to screen you for mental health conditions. And then overwhelmingly, there's a positive indication for at least one mental health service, one mental health condition. And what does that mean in terms of what we should be doing? These are overwhelmingly people who are completely unconnected from any part of the mental health system. These are people who are looking for help and don't have it yet. This is all unmet mental health need. And so what does that mean for people in this room, for advocates, for policymakers, for providers? Let's just start with providers. If you're thinking about where you should be putting your services, it seems to me you should be putting your services where the most need are. And one of the things that's wonderful about this map, which you can go look at for free and download on both Mental Health America's website, as Maddie said, and Mental Health America of Illinois' website, you can look at your zip code and see what the problem is, what are the most serious problems. So among the things, just for example, we've noticed, yes, there are these nodes, but a couple of zip codes that stood out to me were in the Cook County area. Places where there are colleges and universities have a higher rate of depression and suicidal ideation. So the zip code where until recently I lived, right near DePaul, the zip codes in Evanston where there is Northwestern University, the zip code where the University of Chicago is, et cetera, they have more problems. That's not surprising. It seems to me that information should be useful to those schools in terms of thinking about what they need to do to help with folks. Then, if you're a provider, where should you put your services? And also, it seems to me, if you listen to what the answers we got here, what do we need to do differently that we're not doing? If we have people who say, I'm going to handle this problem on my own, what that probably means is they don't want to talk to a mental health professional today. They might in some future day. But this is an opportunity to engage people before they may become sick, really sick, or sicker, or have more problems with their mental health condition. And so how would you reach that? Well, one of the things that the data showed, as Maddie demonstrated, is these are overwhelmingly young people. Okay, now so there's an obvious answer to why that's true. People my age, really ancient, don't look for health care, including mental health care, on the internet. People who are young look for everything on the internet. So it's not surprising that the data skews young. And as we have learned, every year that we have been accumulating this data, the data skews younger and younger, which is both a serious problem and a very important opportunity. It supports the need for the controversial, but I think important, screening in schools, starting at an early age. We have people who are taking these screens at very early ages, grade school, not just high school. And so we're lucky in Illinois that we have a mandate for schools to have screening. This is something you should advocate for. But it also suggests that screening is not enough. They can take advantage of our screening if they wish. They can partner with us in various ways. As Maddie has suggested, you can contact Maddie at Mental Health America, who's our expert, and she will be happy to partner with a school to help figure this out. But it also suggests that we have to think much more, no matter what the age group is, about outreach, about having more and more efforts to communicate that mental health services are available, that we will be happy to help you, to convince people who say, I don't want to get any help yet, that help is easy to get if it is, and to make it easy to get. And that we are not doing. We are getting better at that, of doing outreach, but this is really, in my view, this data is a cry for outreach to tell people that they can get help. So other ways to use this. So yes, it can help determine where providers want to put their services geographically, but it also, of course, is an advocacy tool for individual legislators. So the data is available by county. You can figure out whether you can argue to the state, to the governor, that I need more services in my legislative district because I have a higher incidence of this. So this is you can do advocacies for more money for that be dedicated to you, to your district that you represent. And again, because we have this data in Cook County down to the zip code, this is something that an alder person could do who represents just one of the 50 wards in our city, or in the townships across Cook County, or the suburbs across Cook County. You can make that kind of advocacy. If you're a county commissioner, you should be looking at this. You're a county public health department, you can look at this data and see, what is the problem in my county? Am I the worst county in Illinois? You can look and say, am I the worst state in the country? Or am I doing better than everyone else? In which case, maybe you want to say, well, it's not this condition. This is the condition that I'm doing the least well about. So it seems to me you've got advocacy to legislators, advocacy to county officials, advocacy to local officials, county health departments, city health departments in a big city like Chicago. I'm pretty sure, Maddie, you can correct me if I'm wrong. We're the only county where this data has been broken down by zip code. That cost Maddie a lot of time and effort, and we were lucky to have support from Lundberg Pharmaceutical to do that here in Cook County. But with funds, with enough money, Maddie will do it everywhere, and at least where the data is available. So it seems to me that all of this data suggests really several things. One, services need to be available online, or references to services, because we have people who say, I don't want to do anything yet. So we need to say, how are we going to help that, make that be effective, that people get connected. More outreach in a variety of other ways, whether it's advertisements or school posters or all of those things. And then focusing on the right things. This is an opportunity for early intervention, because almost all of the folks who are saying testing positive have not gotten any help. That probably suggests, we hope that suggests, that they're not so seriously ill that they need to be in a hospital or need to get other care, but they may need that down the road. And therefore, this is an opportunity to connect with them before something bad happens. This is a really powerful argument you can make to your legislature, to your county health department about early intervention. Reach out to people before they're so sick that they come to your attention in an unpleasant way for them and perhaps for us. Maddie, you want to have anything to add to what I've just said, or correct?
No, I think that was fantastic. Thank you, Mark.
Happy to answer questions.
Hi, Mark.
Hi, how are you?
Good to see you again. Well, in person, not virtual. But I was curious if you all have received any negative feedback, I guess, about the screening tools from clinicians who may feel that the tools are not as effective as somebody being assessed formally.
So those things do two different things. So the screening is about identification. It's not a diagnostic tool in the sense that you test positive, we know what treatment you should get. We give people feedback on the results of the test, so they can decide what to do, to go to a clinician or go to some place to get mental health services. And whoever is doing that should, of course, make their own independent assessment. I don't think any competent clinician would say, oh, you tested positive for depression, I know exactly what you have and exactly what you need. No, the clinician would make their own assessment. So I think I agree completely with what I take to be the point of your question. This is not a substitute for an assessment that would be made to decide whether and what care you need to help with whatever condition you are presenting. It's a way for someone anonymously, freely, confidentially, and in an evidence-based way to sort of do a self-assessment to decide whether they may want to get more help. Because a test has suggested that whatever their fear brought them to our test site has been confirmed that they may have a condition that might be helped by going to get help from some competent person to do that. So we're not doing clinical assessments.
No, I definitely think it's a great tool. I promote it all the time. And the people that I've promoted it to, they have been hesitant to see a clinician to have those formal assessments. So
Yes.
being able to have the screening definitely helps.
Yeah, I mean, you get screened, you can decide to do nothing. That's your choice. This is just more information for you. And if you're in a position where you feel comfortable to go and get help based on the information you're getting from our website, that's marvelous.
Yes, it is.
Okay.
Do you have a question? Joe? Okay. Great. Anyone else? Well, wonderful. Maddie, thank you so much for joining us virtually, and thank you for your work. Mark, thank you so much. And if you too would like to be in the remarkable position that Mark is in, where Maddie does a bunch of work and then he gets to show it off, as affiliates, folks, right? As affiliates, you have access to this data. If you can get funding like Mark did, you can drill down even further into your county's data. So please keep Maddie in mind. Thanks, Maddie. See you on the other side. All right, folks, we are coming to the end of our meeting, believe it or not. Thank you so much for continuing to be attentive and sharing your energy with our presenters. So, our final presentation for today are more advocacy and policy heavy hitters. You know them as the RPC cluster leads, and they're going to finish out our day with an update on what they're seeing in their clusters, what you're bringing to them, and they'll flag some of the good work you're all doing. So we've got Ben Harrington, Barb Johnston, Shanna Mulvihill, policy heavy hitters. Take it away, Ben.
Well, good afternoon. It's my pleasure to be here. I have a minor confession. I am a mental health nerd. Can I get a woohoo? Any more nerds out there in the audience? Woohoo! Come on. Let's hear you. I know you all are nerds, so y'all can handle what we're going to talk about. We're going to get to some nerd stuff. We're going to talk about how we pay for all this stuff, right? And so every state is sort of like an affiliate. We have a phrase, if you've met one affiliate, you've only met one affiliate. It's the same with the states. If you met one state, you've only met one state. Each has their own approach to financing, the various strategies. Some states may do all of these things: income tax, sales tax, property tax, service taxes. Some states may select some of them, right? So yeah, it's very much a process where states have to figure it out. You know, we don't always need to talk just about like Medicaid and how Medicaid is financed. The feds are going to pay 60%-ish. The state still has to figure out how it's going to do the balance. So they've got to find a way to generate some income. Now, in Tennessee, I could tell you how we do that, but what I need to remind you is there are a large number of red states, and taxes are really a very ugly word in the red states. If it is generating enough revenue, then they're okay with that. If it's not generating enough, that, we got problems, because they don't want to have to tell their constituents, we got to tinker with the tax rate to collect more money. So there's some issues. So that was the first thing I needed to tell you. Tennessee has been in a position that's mostly driven by sales tax. So they've been able to do some things because sales tax have outpaced projected collections for about the 32 years I've been a CEO. they've been able to repeal the income tax in the state for capital gains, that sort of thing, and almost all of the grocery tax has been repealed. So that's something to keep in mind. In Tennessee, at least, where we were doing well, they had an opportunity to cut back on some things. And that's because sales tax has been fairly recession-proof. We were very much afraid during the pandemic. You know, you might recall those days where the grocery store shelves got picked clean and you sent folks home and, you know, you were wondering, oh my gosh, how are we going to make it? Well, the legislators were concerned, oh my gosh, are we going to collect enough sales tax money to handle the budget that we've approved, right? So they were very much concerned. It didn't work out the way they were fearing, you know, because people need stuff. They need to buy groceries. They need to order what they order online from Amazon or whatever, and we certainly paid for at least a dozen Amazon drivers at our house, right? So sales tax is fairly recession-proof. One thing I do want folks to remember is, like any good scandal, where you should always follow the money in the states. If you're trying to figure out how things are going to get financed, you always got to follow the money. So in Tennessee, here's a snapshot on the right-hand side. And this is from very late April of 26, right? So late April of 26, we were $251 million above estimate for sales taxes, $421 million above estimate for corporate taxes. Fuel taxes were below estimate by $6 million. There's a reason why this guy is talking to you about that. I'll get to it at the last slide. And then other service taxes above $98 million. All said, that really put us in a good shape, because towards the end of the fiscal year, we had $776 million above revenue projections, and that meant they could enter the last phase of the legislative session and deal with all the bills that had gotten passed that had a fiscal note, you know, and that were then going to stack up against the next fiscal year. So those things were very much to be considered. Now, every state is different. You know, some states are, quote, sales tax states. Tennessee is one of those. The leader is Louisiana. Tennessee's next. Tennessee has actually a two-stage process. 7% goes to the state. Up to 2.75% can be county-based or metropolitan area-based. So in Knoxville, it's 9.25%. So some folks go across the border to the next county over because their county sales tax is different. So you can see where your state is here. But the leader board is Louisiana, Tennessee, Washington, Arkansas, et cetera. So sales taxes are most important vehicle. So building your state and local budget soup, as I call it, right? So there are a number of things to keep in mind. Revenue forecast is extremely important. Your budget process at your state, how does that work? And then the governor's budget. So I'm going to tell you a little bit about Tennessee. So from the get-go in the fiscal year, there is revenue forecast. That comes out every 15th of the month. Department of Finance and Administration gives its update from the prior month. What do the collections look like for the various moving parts? That's extremely important to follow. If we start the fiscal year and we're ahead of projections, then that kind of steamrolls. If we are below projections, then everyone starts to get real tense, right? So what happens in August of every year, the State Department of Mental Health starts its internal dialogue about what they want to try to do with their budget the following year. Then they finally get to visit with Finance and Administration in October, maybe early November, to share that draft plan. And then there'll be the actual presentation to the governor. Oh, caramba. Okay, so a lot of things happen there, right? I got the sign from Jackie. So they will make the presentation. The governor will come forward in February and say, here's the budget. And everyone goes, uh-oh, we didn't get what we wanted. But that starts a 90-day sprint. It's called in Tennessee the behind the budget process, because we're going to wait to see where the rest of those projections get us, right? And so the rest of those projections are going to be real important by the time the legislature tries to do the budget in April or early May. Now, we have something called the behind the budget process. The governor will come back once he has the full projection and go, okay, we've got extra money. Can't get too giddy. Some of that is always going to go to the rainy day fund. The rest is going to go to the backroom deal, right? And there's going to be some negotiation on the side. In Florida, there is sort of a similar process. It's a kind of a backroom thing. They call it a sprinkle, but essentially the leader of the Senate or the leader of the House has carte blanche with some of that money to decide where they want it to go, and they call it a sprinkle. But it still comes back down to this thing. If you follow the forecast revenue, then you can figure out where there's going to be money available. Local community governments are kind of the same thing. They're paying attention to their sales revenue, sales tax revenue forecast. They're looking at their own personal property tax, like on my house, that sort of thing. They're also looking at their service taxes. In Knox County, they have a service tax on a license plate, right? And now there's talk about wanting to repeal that. I'm kind of against it because it helps pay for some local government contracts. So I'm going to wrap up here and mention the sinkholes that you could step in and you'll fall into deep doo-doo, if you will. So state can have reduced revenue streams if they are too dependent on certain things, like Oklahoma, Texas, Louisiana, really tied to oil production. Property tax states. Florida is threatening to repeal the property tax. Well, wait a minute. That's how all sorts of communities are funding their services. So there's a real issue there. Marijuana tax. In Colorado, they passed a marijuana tax when they legalized marijuana, and not a nickel went to addiction services. That was a dilemma. Now, I promised I'd get to this one earlier, fuel taxes. We got a problem. In the pandemic, not enough people were driving because they were homebound, so they didn't collect enough money for the fuel tax fund. Bridges, roads need to be repaired, that sort of thing. So there's a movement. First was tried by the Republicans, never passed. Now it's been rebranded called Pot for Potholes. Clever, but I got an issue with it. My issue is today's marijuana, folks, is a lot different than when Ben was young and stupid. So if we were going to legalize it, we got to regulate it. And so there's some issues there. Another issue is robbing from Peter to pay Paul, the school voucher thing, to pay for kids going to private schools. It's going to steal money from public schools. Eventually, that's going to get caught up with, how do you fill that hole? Knox County government, where I am, had $8 million deficit just announced, and they had to lay off a bunch of people right before the school year. So the last rob from Peter to pay Paul is there's something where, like the state government wanted to do it. They wanted to build a new hospital in Knoxville. I was glad. I fought for it, got all the legislative signatures. They didn't have the money, except they did. The legislator said, well, you know, there's all this money in the opioid abatement fund. And because legislators have the power of the purse, if it's not in the budget, could be, as long as we steal it from that fund. So they did. They allocated $25 million. So I'm concerned about that appropriation of funds, but also kind of happy about the new beds I'm getting. So thank you.
Is this on? Yeah, great. Okay. So everybody's talking about follow the dollar, right? This is about the money. So we're going to talk a little bit about 988 and the money. Who here knows about 988? Okay, so I expected everyone here to raise your hand. So in New Jersey, we have and are in the process of building a very, very comprehensive continuity of care for all kinds of behavioral health crises. So 988, as you all know, is someone to call, which is the helpline, someone to come, which are mobile crisis teams, and somewhere to go. And that somewhere to go component is two parts. One are crisis receiving stabilization centers, which are open 24 hours and can provide all kinds of clinical support for mental health, substance use, suicide, all kinds of behavioral health crises, and are no wrong door, and they are phenomenal. We have 5 throughout the state that are planned, and we also have a component called crisis diversion homes, which are longer term. You can see it's an entire continuity of care on the voluntary side. A huge gap, breakthrough, doesn't exist. We all get phone calls all the time. Where do I send my loved one? Where do I send my friend? These are the answers. So in New Jersey, we have paid for, in our budget, someone to call and someone to come, so the mobile crisis teams. So what happened in our budget this year is crisis receiving and stabilization centers are not yet paid for. And we had very much intended to, and it's going to be, I'm going to talk about what Ben's talking about, is a fee. And a fee is different than a tax because fees, generally, taxes have to have a stronger approval. Fees sometimes don't. In New Jersey, this fee did. Fees are targeted to how they're spent, and fees need to match exactly what the service is for. So this fee was, you all know about the ability of us to put a tax on telecom, a fee. I'm sorry, used the wrong language, a fee on telecom, and we estimated it would be 40 cents a month on phones, cell phones, and that's less than $5 a year. We said it was less than a cup of coffee to provide all these phenomenal services for individuals. And what happened was we had some legislators, we had changes in administration, and the fee was dropped and we were told no fee. So then we changed our advocacy to appropriation, and we were very optimistic that we were going to have the appropriation to fund these crisis receiving and stabilization centers, and at the last moment, during the budget talks, we lost our funding. And so what are we doing right now? Advocacy continues. So we are working very hard. You'll see articles in the media about it. Media has really been phenomenal about exposing the issue. We've met with the commissioner, we've met with the governor. We have our legislators who are so proactive and really love this program, and they're meeting with the governor. So we are re-educating all legislators. We have new bills that have been submitted, and we're getting every legislator to sign on. So basically, that's where we are. It's not a happy story, but it's an optimistic end, because I'm going to talk to you in Anaheim in December and tell you all that this program has been funded. So it's not a tax, it's a fee.
Okay, that's weird. Okay, so I'm going to be short and sweet here. I just wanted to just share some takeaways from today that I had kind of written down as notes as I kind of thought about, the topics we discussed today. The first one that I was thinking about a lot is about how we as affiliates have an opportunity to lead by example. And the one that I thought about that during was the workplace mental health example, where we had organizations that talked about many of the things that they are doing to provide a really healthy workplace themselves, and that really sets an example for other employers in their area that they serve, but also really gives them, in my view, credibility when they are offering mental health services or education or trainings or other things, if they can really like point to the things that they're doing and point to their own bell seal when they're promoting that program. The second takeaway that I really have been thinking about from today is how much connections matter. So whether that's with legislators or Medicaid directors or just, partners and those collaborations that where we may have similar goals and interests with other organizations or providers or others, how important that really is in our advocacy work, as well as just our connections with one another through this work, so we can call up another affiliate and talk about something that's happening in our state and get some feedback. And the final one is just really about the theme in general, and that's about that we need to keep pushing back. This has been a really challenging time for so many of us in this work. And, a lot of funding has been cut for programs and services that we operate. And people we serve, some of whom are some of the most vulnerable, are essentially under attack. And that's really hard to deal with on a day-to-day basis. And it can be really disheartening and sometimes just really hard to keep going. And for me, I think that's a big part of what the RPC is all about, right? That we're sort of all in this together, and we can support each other through the tough times as well as celebrate the good stuff too. So whether that's the cluster calls and meetings or meetings like this, we can lift each other up, we can celebrate those wins, we can commiserate together sometimes, but that we can do those things together as a group and as affiliates and as folks who all believe in really working together for the same cause. So thank you.
Thank you so much, folks. Well, we have our RPC leads. Any questions for them? All right. Well, thank you so much. And I just want to also speak thank you for our relationship. Shanna, when you're standing there talking about the camaraderie, I need you three for many reasons. So thank you so much for being on my team and being on the RPC team. So folks, it has come to an end. Thank you so much for joining us here. I have a few notes to share with you before we disperse. I want to make sure that you all know that October 8th and 9th is the 2026 Mental Health America Conference. We'll get that conference QR slide up in just a second. You also have QR codes on some flyers on your table. Please come to DC. Come celebrate more good days together. We'll be thinking about connecting people to the right support at the right time and recognizing that good is defined by your unique experience with mental health and wellness. So again, please join us for our conference. It's a wonderful opportunity to engage in the camaraderie and the collegial vibe that Shanna was talking about. Our next RPC meeting will be in Anaheim, California, at the same time as the Council for State Legislators meet the first week of December. Before we finish our day, I would like to give one more thank you to our funders. We couldn't be here without AbbVie, Alkermes, the Bazooki Group, Bristol Myers Squibb, Compass, Definium, Eli Lilly, Johnson & Johnson, Neurocrine, Otsuka, Pfizer, Supernus, and Teva. I'm also eternally grateful to all of my Mental Health America colleagues. It was really exciting to plan this meeting with so much support from them. There's many of them in the room. Several have spoken today, several have not. If you are one of those who have helped me, just raise your hand because I want to see these hands go up. Jackie, Tim, Carrie, Mary, thank you. We also have Michael and Susan sitting outside, so I'm really thrilled that my colleagues all turned up for me today. Thank you, everyone, and we'll see you soon. Happy travels. All right. Thank you, too.